Good afternoon. Welcome to the Assembly Health Committee. We're going to get our agenda going here. We do not yet have a quorum established. We will proceed as a subcommittee. I just want to remind those presenting on bills today that we have a limit of 2 witnesses in favor and 2 witnesses in opposition, each with 3 minutes of testimony allocated. Others will then be invited to offer their support or their opposition, but no further testimony unless other arrangements have been made. This afternoon we will be joined by Assemblymember Julia Brownlee and Anthony Adams, replacing Hector De La Torre and Bill Emerson in that order. Mr. Adams is with us. Thank you for joining us this afternoon. And we've removed the following bills from today's calendar: AB 2112, that was my bill, and AB 2127 by Mr. Nastandi. Those have both been pulled from today's calendar. Our first bill on consent calendar, we have item 3, AB 1913 by Mr. Tirico, and item 11, AB 2248 by Mr. Hernandez. And we will address the consent calendar later once we've established a quorum. Our first bill and file item number 1, AB 1759. I'd ask Mr. Blumenfield to please come forward. Mr. Blumenfield, just before you start with your presentation, welcome this afternoon. I'm going to excuse myself quickly and turn the gavel to Ms. Lowenthal, who will chair this hearing until my return. I've got to go present a bill quickly, but welcome, and the floor is yours. Thank you.
Thank you very much, Mr. Chair, and now Madam Chair. Members, Madam Chair, I rise today in support of AB 1759. It has to do with health plans. Specifically, what this bill does is it's meant to protect businesses and it's meant to protect employees. Right now, under a loophole in the law, insurance companies are able to raise their rates in the middle of a contract. Not talking about after a contract, not through a legitimate competitive market situation, but in the middle of a contract. And this is causing enormous stress to businesses and to the employees who rely on insurance through those businesses, because one of the fundamentals of business is you need to know what your cost inputs are going to be for that year. And in these very difficult times, this can make or break different businesses. And the loophole basically has to do with changing in enrollment. So with the downgrading in with the economic recession, a lot of companies had to scale back. Thank you. I'll be brief then, quickly. The Kaiser Foundation notes, in the absence of employer-offered coverage, both low- and middle-income workers are at risk of being uninsured, having few options. The supporters of this bill run the gamut from the Valley Industry Commerce Association to California school employees, water agencies, Teachers Association, AFSCME, and legal aid groups. It's got a wide variety of support, and I ask for your aye vote.
Thank you. 2 witnesses in support.
Madam Chairman, I'm Jim Garrison, and I'm representing Pacific Federal Insurance Corporation, which is the bill sponsor. Pacific Federal's primary business is administration and consulting to group health care purchasers, to corporations purchasing health care. Under California law, group health care service plans are prohibited from changing rates for the length of the contract. And the change in premium rates is covered both under law pertaining to DMHC and to Department of Insurance. There is a loophole, however, in the current law where the law permits a mid-year rate change when authorized or required in group contract. As a result of the loophole, without exception, all health plans now include provisions to allow the health plans to unilaterally cancel the rate guarantee during this 1-year rate guarantee period. All health plans include a provision currently that says that they have the right to change the rates, to cancel the rate guarantee if enrollment goes up or down by more than 10%. This is unilateral to the health plan. The buyer, the purchaser, has no say in this issue. But even more dramatically, health plans are including even more expanded language giving them much broader unilateral ability to cancel or rescind the rate guarantee. For example, change in demographic factor, change in average family size, change in subscriber distribution, number of subscribers, number of health plans offered, benefit design, and employer formulas. These are not items I made up. These are items that have been included by health plans in contracts to negate the one-year rate guarantee for large group purchasers. In opposition letters, the health plans state that employers voluntarily, fully, or mutually agree to inclusion of contract provisions which would allow the health plan to unilaterally cancel the rate guarantee and change the rates mid-contract. Health plans would like you to believe that there's some mutual agreement with the employer allowing the health plan to include provisions to cancel the employer's rate guarantee during this one-year rate guarantee period. There are no mutual negotiations or agreement. Health plans decline to remove these provisions. If you don't like it, you take your business to another health plan. This is detrimental not only to the employer, which is downsizing, but that's adding new employees, even attempting to grow in this cycle. I strongly request that the committee here support AB 1759 and close this loophole, which allows the health plans to cancel the rate guarantee. Thank you.
Next witness.
Good afternoon. My name is Barbara Siegel. I'm an attorney with Neighborhood Legal Services in Los Angeles County. At Neighborhood Legal Services, we serve approximately 70,000 individuals a year, particularly low-income individuals. One of our premier programs is our Health Consumer Center, which is a patient rights advocacy program for low-income residents of the county. While many of the people that call us are eligible for government health insurance benefits, a huge portion actually are not eligible for those benefits and must purchase insurance through their employer or in an open market. By far, the largest barrier that these individuals complain to us about is the cost of insurance. The proposal of AB 1759 will assure the consumers that we serve that their costs are going to be stable for that 1 year. There is no question in these economic downturns that any increase in cost to the employer is passed on to the employee. In fact, in a study performed by Kaiser Family Foundation, 15% of employers said that they would pass on the cost to their employees, and an additional 21% said they would not only pass on the cost to the employees, but they would also decrease the benefits in order to contain that cost. Another study demonstrated that from 1999 to 2009, there was a 131% increase in premiums for employers. Of that amount, 128% was passed on to the employee. And therefore, this bill will protect the consumer, who is the ultimate user of the health product we are talking about. It is particularly interesting to me that insurance plans are in the business of risk assessment, and yet they are asking the state to relieve them of their own analysis of their own risk. That seems ultimately unfair to the consumer. This bill will protect the consumer, and we fully support it. Thank you very much.
Thank you. For the other witnesses in support, give us your name, affiliation, and your position.
Amanda Levy on behalf of the California Psychological Association in support.
Tim Madden representing the California chapter of the American College of Emergency Physicians in support.
Teresa Stark with the California Medical Association in support.
Patrick Henning on behalf of the California State Council of Labor is to help bring some stability to these healthcare prices in support.
Seth Bramble on behalf of the California Teachers Association in support.
Are there witnesses in opposition? Does Nathan want to?
Madam Chair, while we're waiting for them, may I add that I agreed the committee analysis asked for 2 amendments, and I wanted to make it clear that I'm accepting the amendments about striking out the word demographics and adding the additional co-authors of Huffman and Yamada.
Thank you. Please proceed.
Madam Chair and members, Bill Worley with Kaiser Permanente. We are in opposition to this bill. This bill has a pretty direct impact on Kaiser Permanente because almost exclusively we offer what is considered fully insured insurance in California, regulated by state law, unlike the sponsors of this measure who primarily are in the business of offering insurance which is not regulated by state law. The case that you have heard, I think it is really important for the members to understand, would apply only to organizations like Kaiser that are regulated under state law. The sponsors would be exempt from the bill, both under federal law and because, in general, the type of business they offer is self-insured business, which pays claims day in and day out, so that changes in enrollment and demographics are automatically reflected in their experience. So this bill applies one set of rules to their competitors, Kaiser Permanente and others, but not to themselves. Second, on the merits of the bill, it has been suggested that this is uniformly hurtful to employers, and that is simply not the case. In the district that the sponsor is from, we have 4 examples. I really don't want to name the names of the companies, but an example of one business in Van Nuys that had a group of employees. A 55-year-old left in March of that year. That person was replaced by a 24-year-old, and so their premium was decreased. We had a case. These are all just Kaiser examples that were all within the region of the bill's proponents. We had one case where a firm had 2 employees at the start of the year. Because they were successful, they added 6 more employees. That decreased their rate, their risk profile, and their rate decreased. These are standard terms. We actually have, Kaiser Permanente has this term in our contract with the PERS system. And it gets to what the author said, frankly, in his opening, which is that you sort of have to know what you're getting into. When you have a contract with a business, you understand what the group of people who are employees of the firm at that time, age mix primarily, what that looks like. Our contracts routinely say that we will absorb changes within a range. But if things change dramatically, then we reserve the right to go back and look at what the risk mix looks like at that point and make a premium adjustment. As I indicated, that happens automatically, and it happens both up and down. So this bill would be hurtful by definition to as many people as it would help. And it is, we think, frankly, somewhat unfair to put a set of rules like this on half of the market when the proponents are not going to be subject to them. For those reasons, we're opposed.
Madam Chair and members, Dan Chick with HealthNet. We, too, are also opposed to this bill. We do contain these provisions in our contract that allow these rates to fluctuate. We do so primarily so that we don't contract for one group and receive a completely different one. We work on very narrow margins based upon the risks that we've calculated. And in the instance of an employer who, say, delivers 1,000 employees and then within a few months, due to the downturn in the economy, they have 600 employees, that risk pool is going to look much different than what we had contracted for. So although we don't exercise these provisions frequently, we are in the business of gaining business and retaining business. But when necessary, we need to reserve the right to adjust the rates accordingly. As the bill's drafted, it would also include a prohibition on changing. For instance, if a company is primarily located in, say, the expensive Bay Area were to move to the cheaper Southern California area, it would prohibit adjustment in the rates for those kind of demographic changes. These are things that, we adjust as necessary. HealthNet is one of the first companies I know of to, when companies get into trouble, to revisit their contract, to provide for lesser or different levels of coverages should they fall on hard times. Again, we're in the business of finding and covering and retaining business, and for, as inferred that we would go willy-nilly unilaterally changing people's contract rates after the initiation of the contract is just not our business practice. But we do need to reserve the right to keep these in contract. Otherwise, you'll have one group of individuals able to put another private group, contract group, at financial risk for something that we had contracted for and was not delivered. And for those reasons, we are opposed.
Thank you. Anyone else in opposition? Witnesses, give your name, affiliation, please.
Manolo Platine, Blue Shield of California, in opposition.
Jason Gappart with the Association of California Life and Health Insurance Companies, in opposition.
Nick Luizos. California Association of Health Plans, in opposition. Thanks.
Thank you very much. Questions from members? Mr. Adams.
Thank you very much, Madam Chair. Mr. Blumenfield, one of the things I'm having a difficult time understanding is this notion of unilateral control. It strikes me that just by way of an example, even in our own health plans, we have limitations upon which we can change it. We have to usually wait till open enrollment before we can make a substantive change in our health plans as defined. However, within the confines of that, though, we are given certain change of life provisions that afford us the ability to make those changes. That would seem to me to create the very reciprocity that your bill seems, or that is to say, excuse me, that your witnesses seem to claim don't exist. And I'm wondering if you can address my perceived disparity between those two statements.
I'm not sure if I fully understand what I think you're saying. I mean, these contracts are typically a year long, for big businesses, and they don't generally fluctuate that much. But there is that sort of open enrollment period for both sides, because every year you have a contract negotiation and you either redo your policy or you do a different policy, and that's all I'm saying is that's the appropriate time to decide what the policy is going to look like.
But right now your witnesses are claiming that there is no reciprocity, that the insurance company has the authority to come in. Presumably under their contract they are given that authority, but be that as it may, assume that is or isn't true, it doesn't matter. But they come in midway through a contract and make rate adjustments according to their actuarial tables, their needs, whatever the case may be. But the presumption that is being asserted is that the policy holder, whether it be a group policy holder or an individual, doesn't have the same discretion. Yet in my experience, those contracts do afford the individual or the group the ability to do that with any kind of change of life provisions. So if, for instance, you get married, or if, God forbid, you should lose a child, or something should change structurally in your family, you should move, for instance, you have the capacity to make these adjustments. And so I'm trying to understand where the so-called disparity exists that causes this sort of unilateral approach that your witnesses are claiming exists.
Mr. Adams, if I can address the issue, because it is something that does occur during the contract period. If you can imagine, the contract stipulates rates for single, two-party, family. The rates are all set. Clearly, the movement from a single getting married, like change of life, puts you into rate category that's defined in the contract. So there's no question that that's permissible to move within the rates are stipulated with the contract based upon your family situation. And that's going to happen through the course of a year. Someone gets married, spouse gets a job. They're going to move up and down within the rates, but they're spelled out in the contract. What we're really talking about is not the self-adjusting rates. Like an example given by the health plans, they were referring to contracts for smaller employers, which also have a rate under 30, 35 to 40 different rate bands. Those are specified in the contract too. Certainly a change in life by age will bounce you up and down because those rates are spelled out. What we're really talking about is wiping the chalkboard to these rates and then sending you another month saying, here are the new set of rates you have to deal and operate under for the balance of the year.
And I don't know if this is necessarily a question for the witness, the opposition, Madam Chair, but with your permission, I'd like to hear from the opposition witnesses whether or not that is their understanding of the structure that exists, and more specifically, if that is in fact something that's contracted for. And we will return to the question because you did raise, I think, a salient point that I'd like to return to, and that is this question of unfair bargaining advantage. Because even though technically I guess that was really more a question for a judicial committee than it is for health, I'm not sure that it's going to judicial, and I'd like to have that discussion at least briefly, if I may. But if I could hear from the opposition witnesses.
Well, with respect to small group, which is the easiest case to make, when we have a firm, as we routinely do, I cited 4 examples where a few months after the contract, they hire new people who are distinctly younger or older than the people that were there before, we recalculate those rates. And that is exactly what this bill would prevent. And frankly, I can understand that there are some people who are disadvantaged by that, but I don't think unfairly. They are going to pay a different rate based on a change in their age mix. Our point is that there are many, many, many employers who are benefited, and it happens automatically, and this bill will prevent that.
Does the rate structure fluctuate? The assertion is that you can, quote unquote, wipe the slate clean and change the rate structure in its entirety. Are those rate changes consistent with something that the policyholder would have a reasonable expectation of knowing that the changes would result in a rate change?
Absolutely.
And more specifically, what those rate changes actually would be?
Right. We have an overall rate structure for the year for a geographic region based on age bands and the number of employees in each age. So it is a knowable thing if in advance that if your age mix changes, for example, one of the businesses that I cited hired 6 new employees. They were all younger than the 2 employees that were there at the start of the year. And so the overall age mix of the policy of the firm changed. Their rate dropped dramatically. And that's all according to a standard formula that's perfectly available to anybody.
Just to be crystal clear on this point,
yes.
Whether it be, I believe this bill deals with, this is the bill that deals with through the life of the contract, is that correct?
That's right.
Right. Through the life of the contract, are you asserting then that the rates may change, but the rate structure does not?
Correct. That's right.
Okay.
We don't say, to give an example of where I think you're going, we're going to charge a whole new rate for 55-year-olds. We don't do that. Absolutely not.
And I'm sorry, from the...
Mr. Adams, if I can get a chance to clarify. In the California marketplace, we're talking about 2 different types of employer purchasers. An employer purchaser, which is less than 50 employees, where the contract issued has rates specified by age. They're fixed in the contract. If your age changed or if your life situation changes, family, they're already fixed in the contract. Where the abuses occur are in the contracts issued to employers with more than 50 employees. These are not age-rated contracts. The rates do not self-adjust with life changes. You get a rate for a single, rate for a 2-party, children or family situation that is issued to you on the assumption of the purchaser that's a rate guarantee for 1 year.
You're saying an assumption. There is nothing contractually.
Well, the contract leads in, according to state law. These rates are guaranteed for 1 year. When you delve into the fine print, this bill is attempting to protect the purchaser. Terms and conditions are being put in which allow the health plans to change the actual contract rates within that 1 year period.
So are you saying there's conflicting elements of the contract, or are you saying that the contract is contradictory? Are you saying that the contract modifies one clause by getting into a finer point on another?
Sir, it's an issue of state law. There is a loophole in state law that allows the health plans to put in terms and conditions mutually agreed between both parties. But basically, there's no mutual agreement. It's in the contract. It's a take it or leave it.
And I know that there's other members who want to make comments, so I promise to keep this conversation brief. But since you lead into it naturally, can you please make the case for unfair competitive advantage? And specifically, can you address the question, if in fact policyholders, whether they be group or individual, are being treated to an unfair competitive advantage by virtue of this sort of, I guess, onerous ability for the health plans to insinuate themselves, that already is grounds for the dismissal of a contract under current California law. Why is that not a sufficient remedy?
We're dealing with a situation of limited health plans, limited choices. Where are you going to go? The amount of time to get a civil remedy. It cannot be done rapidly enough to do away with the harm caused on the individual employees.
Thank you, Madam Chair.
Mr. Gaines.
Yeah, thank you very much. Just in terms of the competitive nature of the market, it seems to me that in the event that you had a case where rates were going up as a result of additions midterm, that you could always take that out to bid among other competitors in the marketplace to get a better rate. And I think there's also some incentive on the part of the insurance company to want to retain that business. I guess the second point is that I think that this can cut both ways. If the demographic is changing to a younger demographic midterm, you can see an actual improvement of the pool of employees from a rate perspective versus an older demographic.
But the employer doesn't get to decide that. So the employer can't say, we think our workforce has gotten healthier, we're going to lower our rates, and then tell the insurance company we're lowering our rates in the middle of the contract. Whereas the insurance company can do that. It's not all spelled out so neatly in these large employer contracts. They look at it and sort of goes into their black box, and they come back and they say, well, we decided you're going to pay a little bit more right now. If the employers were allowed to do that as well, then there might be that reciprocity. But obviously it would be absurd to let employers decide on their own to unilaterally change how much they're paying in their premium.
But there's nothing from preventing the employer from taking that out to bid again, saying, hey, these
at
rates
the end of
are
the contract. They're locked in for a year-long contract.
Mr. Gaines,
that's not my understanding. I think you can take a group out the bid at any point.
You're correct, Mr. Gaines. What I would like to address the issue, the healthcare purchase and insurance become very complex. Issues of withholding, pre-tax, 125 selections on a federal basis. It is not easy for a employer to make a mid-contract year change, to visit employees, to have a brand new open enrollment, and also to have them reissue their withholding requests. It really puts them in an awkward situation.
I agree there would be some hassle involved in doing it, but I think given the economic conditions here in California, a lot of employers are doing that because things are so tight financially. I think that in my perspective, you've got a relief valve that if things are getting out of hand, you can go ahead, put it out to bid again and get another quote.
I would just like to comment that that's an extreme burden on the employee who has an established relationship with a medical provider that doesn't necessarily contract with the new plan. So it means a complete shift of your own healthcare providers, particularly for people with chronic diseases. That is a major burden.
It could be. It would depend on the groups with each particular health plan, because sometimes those will overlap. They'll have similar contracts.
Seeing no other questions, Mr. Blumenfield, would you like to close?
Respectfully ask for your aye vote on this, and to ask as passed as amended, to pass it as amended.
Thank you, and we still don't have a quorum, so we will ask you to wait until the quorum comes. Thank you. Mr. Chair.
I want to thank Ms. Lowenthal for chairing. Mr. Blumenfield, we will hold that until we establish a quorum.
Thank you.
Next item in order, item 2, file item number 2, AB 1916. Mr. Davis, if you'd like to come forward and present.
Good afternoon, Mr. Chairman and committee members. Today I'm here before the Health Committee to address AB 1916, which seeks to require pharmacies to report to the Board of Pharmacy any occurrence known by the pharmacy of a prescription being furnished to a person other than the patient named on the prescription. It requires that the report shall include any adverse reaction that may have occurred as a result of the person to whom the prescription was furnished using the prescribed drug. And I think it was 2006, the Institute of Medicine had a report called Preventing Medication Errors, and it concluded that 1.5 million preventable medication errors cause harm in our country each year. Tracking these errors, how they occurred and why, has been dismal. The professor, Bruce Lambert of the University of Illinois at Chicago, said, despite all the focus on prevention, there is little evidence of large-scale improvement in the wrong drug error rate. This represents a serious gap in the current knowledge about medical safety. The lack of valid, reliable, efficient method for detecting name confusion errors is the main reason for the gap in our knowledge. It is a fundamental principle of quality control that if a process cannot be measured, it cannot be improved. AB 1916 is an important step in improving medical error tracking, thus allowing us to drive improvement. One of the examples researched by our staff was that in a KCRA report, a citizen by the name of Arnold Bravo a Woodland native, died in August of 2008 after a long battle with liver disease. According to a lawsuit, a pharmaceutical error contributed to his death. Bravo went to then Long's Drugs to fill prescriptions used to fight his disease, where he waited for a liver transplant. Instead of getting medication for Arnold Bravo, he was given Flomax, a medication for someone named Arnold Breyer. According to this suit, the drug sent Bravo's already weak liver into shock, and he died as a result. Current law requires that California hospitals report medication errors that occur within their jurisdiction to the Department of Public Health. Errors due to pharmacies outside hospitals, however, are not being captured by the Board of Pharmacy unless reported by patients. Patients are unlikely to know, oftentimes, where to report such errors. This bill, AB 1916, would instead require the party responsible for the error, the pharmacy, to also report one type of the mistake to the board, a particular prescription drug being provided to the wrong person. This mistaken identity problem, in which a patient gets a drug intended for a different patient, sometimes because of a similar name, can have a tragic consequence and certainly warrants reporting by pharmacies. And ladies and gentlemen, I ask for your aye vote.
Thank you, Mr. Davis. Do you have witnesses to present in support?
I do have a witness in support. Consumers
Union. Yes. Hi, Betsy M. Holt, Special Projects Director for Consumers Union, nonprofit publisher of Consumer Reports. We are also in support of this bill, and we know that medication errors are a very significant problem nationally. The problem is we really don't know the full scope of the problem because, as the Assemblyman described, we don't have a full database on those errors. The Department of Public Health is required under an Alquist bill from a few years ago, SB 1301, to gather from hospitals, from those facilities, a variety of adverse events, including medication errors. And that bill's been in effect for 2 years, and we have some data starting to roll in on that. But we really don't know the scope of pharmacy-generated errors. And that's a hole that this bill aims to plug. Certainly, the tragic case cited by the author exemplifies why this information is needed. It's a matter of public safety, of patient safety. Having this data would enable the Board of Pharmacy to fulfill its obligation to protect Californians and to ensure that pharmacies have in place a drug medication safety plan. And as the Assemblyman just described, it's a fundamental quality control issue that you can't solve a problem, know if you're making any headway on it if you don't have the data to know what the baseline is to begin with. So we urge your aye vote.
Mr. Chair, members of the committee, I'm Gary Passmore with the Congress of California Seniors. And we, of course, agree with the observations made by the representative from Consumers Union about the potential harm that's caused to consumers because of medication errors. I'd like to add that medication errors are also a significant driver in the costs of health care. And to the extent that we can hold those costs, those kinds of costs down with better reporting and better controls, we'll save all consumers costs in the cost of health insurance. And we support this bill.
Thank you. Other witnesses in support? Seeing none, witnesses in opposition.
Mr. Chair, members, Jim Gross on behalf of Medco Health Solutions and the California Pharmacists Association, which are the small retail pharmacies. First, let me apologize to Mr. Davis for our letter being late. We did not catch the amendments until just a day or so ago, and I apologize for that. We don't disagree that medication errors are an important issue, and we don't disagree that reducing medication errors would, in fact, reduce healthcare costs. What we do disagree with is that trying to compile a body of questionable information based upon a limited amount of knowledge of pharmacies and putting it into what appears to be, in essence, a black hole, because we don't know what happens to this information, we don't know how it would be used, we don't know whether the board has any capacity to deal with it. and we don't know how it would be woven in with the current procedures for reporting adverse drug events, all we see is a mandate placed on pharmacy to do something about a problem, but what we're supposed to do does not appear to provide any solution whatsoever and simply drive up pharmacy costs. Now, the members of this committee are well aware that over the last 3 years, this legislature has taken numerous actions to reduce the reimbursements to pharmacies in the Medi-Cal program. Each year, less and less money is available to pharmacy. And now we have a bill that would require a reporting system for the smallest pharmacies for every time somebody said, I think I had an adverse drug event, or, hey, did you give me the right drug or the wrong drug? And I also dispute, frankly, the level of medication errors that are attributable to dispensing by pharmacy, both in mail order and in retail. So we agree there's an issue. This is certainly not the solution to the problem. Thank you.
Mr. Chair, members, Bryce Doherty on behalf of the California Society of Health System Pharmacists. We are pharmacists by trade. However, our practice setting are in those acute care hospitals and or health systems, including the UC system, Sutter, larger systems, and then also independent hospitals. And we too appreciate the intent of the author. Our concern really is from a practical standpoint, this would require any pharmacist in any pharmacy to report to the board any medication that was furnished to a person other than the patient named on the prescription. I have, from time to time, picked up my wife's prescriptions at a pharmacy. If I picked up her medication and I was not the one on that prescription, that pharmacist would be obligated under this bill to report that to the Board of Pharmacy. We are also concerned from a hospital standpoint. Not only are we trying to implement the ALQUIST requirements that were already mentioned, but many, many years ago, Senator Jackie Speer implemented legislation that would require hospitals to have a medical error reduction program in place. We are filling out those reduction programs now, moving to barcoding type technology, and we think that's going to go a long way to take the human error component out of these medication-related errors. Thirdly, in a hospital setting, not only do they have to be state licensed, but many of them are also accredited. A lot of those accrediting requirements already require reporting of adverse events, so some of this information is obviously going to be duplicative of information that these entities and the Federal MedWatch program is also getting. And thirdly, we share our concerns, the concerns of our community pharmacy brethren, which is what is the board going to do with this information once they get it? And those are our general concerns. We look forward to working with the author, but at this time must oppose the bill. Thank you.
Thank you. There's an opposition.
Missy Johnson with the California Retailers Association on behalf of 3,500 chain drug pharmacies throughout the state. Also, my apologies to Mr. Davis for the late notice. We're opposed to the bill because we think it's unnecessary. The current Business and Professions Code already requires pharmacies to undergo a quality assurance program review whenever there is such an occurrence, and those records are currently available to the board. Additionally, Mr. Davis referenced an Institute of Medicine report on medication drug errors, of which there are many, many causes. And as Mr. Gross mentioned, the pharmacy dispensing component is a small piece of that. And we also share the concerns raised in the analysis regarding the broad language and ambiguity of the bill.
Thank you, Ms. Johnson. I'm sorry to cut you off. We've had
No
two
worries.
witnesses in
Thank
opposition,
you.
so if you could just state your name, your affiliation, and your opposition. Thank you.
Jennifer Snyder on behalf of the National Association of Chain Drugstores in opposition as well.
Thank you very much. And again, I just ask witnesses and presenters to comply with the rules of the committee. That's to afford full opportunities for later bills being heard, that we have sufficient time. Any other witnesses in opposition? Seeing none, before I open it up to committee questions, I do want to just clarify in our interaction with your office, Mr. Davis, we've identified some areas of concern that I think you've acknowledged and your staff has acknowledged. I just want to make sure committee members are aware. This does have a dual referral. It will head to Business and Professions Committee, and one of our requests in order for me to support the bill has been for you to address all types of medication errors, not just an error where a patient receives a prescription that belongs to someone else, that was intended for somebody else, but other medication errors, including providing the wrong pharmaceutical formulation to the intended recipient. We'd also ask that the bill should provide direction to the Board of Pharmacy on what they do when they receive the information of a medication error or prescription error, and remove the language regarding adverse reactions to the drug. We think there may be situations where a patient has an adverse reaction to a drug that was not a wrong filling of a prescription. That's better taken up between the patient and the prescribing physician. So those are the parameters of some of the areas that we would expect you to work with for amendments before the Business and Professions, and hopefully in consultation with those that have raised some of their concerns this afternoon. And I assume, I see you nodding your head,
Yes,
that's
sir. We accept
acceptable
all of
to you.
those indicated by you.
Great.
We look forward to working them out in the Business and Professions
Great.
Committee.
And with that, then, thank you, committee members. I do see Mr. Adams has a question.
I guess this is really a question more for Mr. Gross and the members of the opposition. One of the things that I'm concerned about is that both the Republican and the committee analysis both seem to be consistent that the information that's being required to be reported under the prospective law here is already information that the pharmacists are required to document anyway. Is that not the case?
Well, the adverse drug events, there is a system for reporting. And if, in fact, a pharmacist is aware that he or she has provided a drug to the wrong person, they're supposed to rectify it. And we do not think this occurs nearly as often as perhaps the supporters suggest. But yes, that's part of their professional responsibility to report it, deal with it, et cetera. This is now bringing in the regulator into it in a way that we know will result in more paperwork between the regulator and the pharmacy on an ongoing basis, and we're not sure that it will improve anything at all because of our ongoing professional responsibility to deal with those issues.
Mr. Gross, what I don't understand is aside from the adverse, which appears to be an amendment that the author is going to take that's going to preclude that from being part of the reporting requirement,
right.
The other errors that occur that are attributable to the pharmacy do in fact already get documented by the pharmacy as part of the profession's practice.
Right.
I'm having a difficult time understanding why it would be pejorative, other than just the man hours of having to actually fill out the paperwork and everything, to transmit that data in such a way that makes it data available to either policymakers or a regulatory agency that can determine whether or not the frequency of something occurring is symptomatic of a larger problem that needs to be remedied.
Well, you raise the issue of transmission. How do we transmit it? We don't currently transmit that kind of information in that form to the Board of Pharmacy. So that's just
that's an issue, whether you're going to email it or fax it or mail it in?
Right. So all of that has to be compiled. All of that has to be sent to them. And as Mr. Monnings pointed out, what's going to happen to the information from there? What viable use of that information will occur? If you're asking pharmacy to take on an additional responsibility as a small business, make sure that you're getting something for it. I think that's what Mr. Monning pointed out. I don't know what they'll come up with, Mr. Adams, but what I see now is, well, you must be the problem, you report on it, and hopefully something good will come out of it. So when you identify for me that medication errors are an issue, I agree with you. When you don't identify a solution, but all you do is impose upon my client the responsibility to do more work for which they will not be compensated, and you've already reduced the amount you pay for what we do already, I have concerns. So again, if he comes up with a real viable solution to the problem, I suppose we'll take a look at it. At this point, I don't see that.
Well, thank you very much, Mr. Gross. I have to tell you, Mr. Davis, it makes perfect sense to me. It doesn't strike me as arcane or something difficult to comprehend what the collection of data could aid in, which seems to me the ability to even make an informed decision about whether a problem is sufficiently large enough to warrant some action other than the actions that would naturally be taken by a pharmacist acting in good faith in the confines of their professional responsibility. To me, the bill makes good sense, and I'm going to be happy to support it.
Thank you very much.
Thank you, Mr. Adams. I have Mr. Gaines.
Yes, thank you, Chair. I just had a question for Mr. Gross or Mr. Dougherty in terms of, can you go through what the current steps are in the event that there is a problem with a prescription that is offered in error? What happens currently?
Start with the hospital side.
Well, I think we're in a little bit unique situation as a hospital or health system, and I think a little bit of this confusion is what the actual bill says and what the intent of the bill is what the intent of the bill is, because the way the bill is written, it says a pharmacist would have to report to the board anytime a medication is dispensed to somebody other than the person listed on the prescription. So in a hospital setting, furnishing means something, administration of a medication means something, dispensing of a medication means something different. So we need to get clear on what act we're actually trying to regulate. And then number two, is the intent really, if a medication is either administered or dispensed, if it's administered in an inpatient setting by a chart order, it's administered there at the bedside. If it's dispensed, it may be dispensed to the patient for them to take by themselves, or it may be dispensed for them to use once they leave the hospital. If that's the intent, that those medications are being administered or dispensed or furnished to the wrong person, then we can talk about that. But now the current process is, if there is any sort of adverse event or anything medication related, it goes back to the conditions of the hospital license and the accrediting body. And many of those requirements are already required to be reported, particularly if something adverse happens, near-death experience. And also, there are voluntary reporting systems that are placed through the FDA, through MedWatch and the others that are listed in the analysis that captures that information. So we're trying to figure out, we all want to reduce medication-related errors. We're trying to figure out, how is this new approach duplicative of existing requirements, or how is this information going to be more robust in getting us to where somebody like Mr. Adams would like to go?
One point of clarification, Assemblymember Gaines, is that the bill does not compel hospital pharmacies to this policy.
Okay, great, thank you. And I think we had another comment here. And
yeah, I'll just answer your question, and I think the answer that Mr. Davis just gave illustrates our confusion on a lot of aspects of it, because I don't know that we can see that they're not subject to it. In our situation with the retail pharmacies, as I mentioned to Mr. Adams, our responsibility is, first of all, to correct the problem. Second, we do, in fact, record that information. We're subject to audit by the Board of Pharmacy, and if it's a Medi-Cal dispensing, we're subject to the audit by the Department of Health Care Services, and that information will be there. We don't have an objection to that information being made available for purposes of figuring out what the level of medication errors are. What we see this as is being responsible for somebody coming in and telling us something that may or may not be accurate and reporting it. What's wrong with the data that we do have? What's wrong with using the data we do have, where we have documented that in fact there was an error, rather than imposing on us the responsibility to put forth any information somebody came in and just said you gave it to the wrong person? There are lots of confusions that occur outside of the pharmacy that now we seem to be responsible for. So I just don't think a fine point has been put on this bill. And if the issue is, let's figure out the level of medication errors, of which there have been lots of studies, we're willing to participate in that. We think this bill is not where it needs to be to accomplish that goal.
Okay.
Mr. Gaines, is that sufficient for your inquiry?
I think there's one, if I get one more comment, and this, if I can make a comment, and I'll wrap.
Thank you.
Thank you.
Just to add to Jim Gross's comments, there's specific code sections in law that require pharmacies to have a quality assurance program. And as part of that quality assurance program, they're required to report and to collect any adverse drug events as part of that, and have that on hand anytime a pharmacy board licensed inspector is in their facility or in their pharmacy. So, I mean, Jim is very right that we have a process available. It's just that next step of having to send in every report does not seem to be effective to us. If we have it there, if they need it, they can access it. We would suggest that maybe the author possibly look at this program in particular and find ways to strengthen that, and possibly utilize that program to strengthen the involvement in the board and those types of reporting requirements, not this bill.
Okay, I've got real concerns of the bill in its present form. I appreciate, Member Davis, what you're, I think, trying to do. But I've got to qualify that with saying that in all the times I've used a pharmacy with 6 kids, I've never had an error. It actually amazes me, given how many times we've been to the pharmacy over the last 22 years. So I'm not sure it's completely ready to move forward, and cannot support it at this stage. Thank you.
Thank you for your comment.
Thank you, Mr. Gaines. Seeing no other questions, I just want to affirm the author's commitment.
Yes.
The author's commitment to work on these, because I think there is consensus in our committee of the need to frame how this is going to be implemented in a manner that achieves your public policy objective, which is to provide some data collection where there are errors, and to do it in a manner that supports the pharmacy industry as well, to be able to give them, presumably, good database to show the high percentage of good implementation of prescription orders. But we will we'll hold this. We don't have a quorum yet for our vote. We will hold this bill. I will be supporting it for a do pass vote to business and professions, with the understanding that you will take these recommended amendments and work with those who have weighed in today with concerns to help frame it. I see Ms. Hayashi has a question. Please,
Sure.
Ms. Hayashi, and we'll move forward quickly.
Thank you. Thank you, Mr. Chair. And I just have a point of clarification. I want to thank you, Mr. Chair, for working on these set of amendments. And I'm not sure if the opposition has had time to review the amendments, but they're not your amendments, correct? You're opposed to any type of mandatory reporting. Is that the...
If I heard the amendments correctly, I do not believe it would resolve our opposition, but I have not seen them. So.
Okay. So, Mr. Chair, we'll be coming to my committee, which is the Assembly Business and Professions Committee, and look forward to incorporating some of your suggestions. And I'm going to support the bill today, and I look forward to working with you, Mr. Davis.
I look forward to it as well.
Thank you, Ms. Hayashi, and I will reserve the right to pull it back to this committee if we don't feel it's achieved the objectives articulated today. But thank you all. Thank you for your presentation, Mr. Davis. That bill will be on hold until we establish quorum. Thank you.
Thank you, sir.
We're going to move now to file item number 5, Ms. Galgiani, AB 1985.
Thank you, Mr. Chair and members. With the current budget deficit, it's imprudent to find government waste and to increase efficiencies in government spending. Cost savings practices successfully utilized by one state agency should be applied in other state agencies. Assembly Bill 1985 will provide the Department of Corrections and Rehabilitation another tool in which to realize cost savings in their medical health care system. You'll see in the analysis for this bill that it's expected that we'll spend about $2.2 billion this year in prison health care. In 2003, I worked on AB 747, which established maximum allowable price costs for durable medical equipment in the Medi-Cal system. That bill required these maximum allowable price costs so that we would make sure that we weren't spending money paying Nordstrom's prices on one wheelchair and then Target prices on another wheelchair, that those maximum cost prices would be in place so that we would have some continuity and achieve savings. This bill also required the department to establish capped rental reimbursement for specific items like hospital beds, whereas we were finding that we were renting them month after month and we had them for so long that we could have paid for the item twice or 3 times in some cases. This language from AB 747 was adopted into the budget trailer bill. So this year I'm using this previous legislation as a model for cost savings that we can achieve in the prison health system. This bill permits the department to establish a maximum allowable reimbursement rate for durable medical equipment, and secondly, to establish capped rental reimbursement rates for specific items such as hospital beds. Further, it will require the department to adopt this cost savings practice only upon approval of the federal receiver. And I'm happy to say that I am working with the federal receiver, and we're working on the technicalities of the language to make sure that what we have in place fits how they currently procure durable medical equipment. I respectfully ask for your aye vote.
Thank you, Ms. Galgiani. Any witnesses in support? Seeing none. Any witnesses in opposition? Seeing none. Thank you for the presentation, Ms. Galgiani. Let me see, Mr. Adams has a question.
Well, Mr. Galgiani, thank you for bringing the bill forward. There was just one point of clarification I needed, and I was hoping that you could offer us today, and that was this. The analysis seems to imply, it doesn't outright say, but it seems to imply that by emulating the Medi-Cal procedure, we are going to be reducing costs. And the presumption that exists there was that, in fact, that's what happened. that when we applied the same procedure to our Medi-Cal program, that there was a decided cost savings. I just want to affirm
Absolutely.
that did occur.
Yes, absolutely. In fact, with one particular item back in 2003, it was diabetic test strips. We found about $16 million in savings with just that one item, and that was 7 years ago, so prices have gone up since that time.
Excellent. One of the concerns that I think have been raised by our caucus is the idea that potentially this isn't going to result in cost savings, but I do think that, in fact, the example of what happened in Medi-Cal does warrant support for the bill, and be happy to do so.
Absolutely, absolutely. And in some cases, I will point out that with Medi-Cal, we were finding that some wheelchairs were being purchased upwards of $2,500 at the time, when a wheelchair that was almost the same was being purchased for a few $100s. So we did find millions and millions worth of savings. And again, that was many years ago. So the cost for durable medical equipment have soared since that time, just as the cost for all health care in general has soared.
Ms. Salas?
I'd like to move the bill. I think this is a step in the right direction and a smart way to save money.
Thank you.
Thank you, Ms. Salas. We have not yet established a quorum, so we'll have to hold your motion until we establish a quorum. Would you like to close, Ms. Galgi? Oh, I'm sorry, Mr. Gaines?
Yeah, thank you, Chair. Just a question of clarification, because the analysis I'm looking at indicates that the current competitive bid process is not working correctly, and you cited the example about the wheelchair. So I'm just trying to understand why that current process is not working.
I know that the receiver is looking at the whole procurement process right now with corrections, and that's why we're working with him to make sure that what we have in this bill will fit with what they do and give them flexibility to achieve more savings. This is what we did with AB 747 in 2003. We worked directly with the Department of Healthcare Services so that we made sure that the language matched what they actually did in practice. And once we did that, we took the language from our own bill by Assemblymember Matthews, my predecessor, and we put that into the Assembly budget trailer bill. And since that time, we achieved millions and millions of dollars in savings by just taking advantage of the state's purchasing power, because we're essentially able to buy in bulk, like other people would be able to go to Costco and buy, 24 rolls of towels.
Okay, now, will there be flexibility? So if it's determined it makes sense to go to competitive bid, that you would go down that route versus the other methodology?
This doesn't speak to whether it's competitive bid or not competitive bid.
Okay.
This speaks to establishing maximum allowable price costs.
Okay.
So that
All right.
we cap the cost so that we're not paying a Nordstrom rate over here and a Target rate over here, but that they're the same. If we're purchasing the same item, we ought to be paying the same low price instead of a very high price and a very low price.
Okay, great. Thank you.
Thank you.
Any other questions? Seeing no other questions from members, Ms. Galgiani, I want to applaud your effort to try to bring some greater economies to our prison budget in this area.
Thank you.
Would you like to close?
I respectfully ask for your aye vote. Thank you.
Thank you, Ms. Galgiani. We are going to put your bill on hold pending establishment of a quorum.
Thank you very much.
Thank you very much. Committee members, we have sergeants trying to mobilize our next authors, and we will take not an official recess, but a couple-minute break until our next author shows up ready to present. I would like to encourage members and member offices who may be watching. We're still trying to establish a quorum. So members of Health Committee, if you could come join us for the purpose of establishing a quorum, we'd appreciate it. And if sergeants could help put that word out to offices of members as well. Thank you. Hurry up and wait. Good afternoon, Mr. Fuhr. Are you ready to present? Great. This is file item 6, AB 2042. Good afternoon, Mr. Fuhr.
Geez, it's kind of lonely in here, Mr. Monning.
It is. Thank you for joining us.
Yeah. It's a pleasure to be here. So, good afternoon, Mr. Chairman and members of the committee. We all know in this committee that there have been meaningful rate hikes proposed by health insurance companies in the past several months. I'm not going to belabor that point. It's been well established in this committee. But the effect of the unpredictability of these increases is to drive more and more people out of the market and leave them without any health insurance coverage. Give you a sense, the number of people without health insurance, according to UCLA, increased by 2 million people from 2009 from 2008. Think about that. 2 million more people were uninsured. One of the reasons for this is the magnitude and the unpredictability of health insurance rate increases. This bill is a straightforward proposal to begin to help rectify that problem because it stabilizes the individual health care coverage market when it says we shouldn't allow health insurance increases to take place more than once a year. Picture any of us around our kitchen tables trying to figure out with our families how we're going to pay our bills. We can at least attempt to grapple with the magnitude of a problem if we can predict what it's going to be over the course of the next year. Much harder when every couple months, unpredictably, new rate increases befall us, and we have to make sudden decisions about how to reallocate very scarce resources, particularly in a down economy. I want to point out to the committee that I have been listening carefully to the opponents of the bill and have taken already amendments that directly address concerns that they've expressed. One of them is an amendment reflected in what the committee has before it to say that if an enrollee changes geographic region or family composition, that the plan can change the rates to reflect that change. Also, if health insurance is based on a percentage of the cost of providing services, so that then that too does not result when a provider increases her rate. That would not be considered a rate increase because, again, the insurer doesn't have control over that. So we've already taken those amendments, and we've had a very constructive large group meeting with the opposition. I'm listening carefully to what they're talking about in this bill. But I will say the core of this bill is and continues to need to be there ought not be frequent increases throughout the course of a year. Once is enough. And with that, I urge an aye vote, and I have witnesses here in support of the measure, Mr. Chair.
Thank you, Mr. Fuhr. Please present your witnesses.
Beth Capel on behalf of Health Access California. We're pleased to be the sponsor of this measure. In addition to the points that Mr. Fuhr made, we'd also note that the measure says that not only can premiums not be changed more than once a year, but also benefits and cost sharing can only be changed once a year, so that when a consumer buys health insurance for themselves, they know what they're getting into in terms of both premium, their copays, their deductibles, and what kind of benefits they're going to have. Unfortunately, we're seeing instances that are almost like hyperinflation, where where some insurers have threatened constant increases, and that's what this bill is aimed at preventing. Thank you.
Hi, Betsy M. Holtz for Consumers Union. In these uncertain financial times, families more than ever need the certainty of knowing what their health bills are going to be for the year. And this is all the more true in the individual market where the prices are the highest and the costs are the highest. So we urge your aye vote.
Thank you. Other witnesses in support?
Mr. Chair, Seth Bramble on behalf of the California Teachers Association. Mr. Chair, Seth Bramble on behalf of the California Teachers Association. We support this important measure, which will bring affordable and as well as stable health care costs to Californians.
Thank you. Other witnesses in support? Hearing none. Witnesses in opposition?
Well, I thought Mr. Adams was coming forward to be a witness in support, which I would take, by the way, in a second. Thank you for thinking of it anyway.
Thank you, Mr. Chair and members. Nick Luizos with the California Association of Health Plans. We're respectfully opposed 2042. As you know, the committee is considering a number of bills this year that seek to control consumer prices, but in our view do little, if anything, to control the underlying cost of medical care that constitute the vast majority of the healthcare premium dollar. We understand the intent of the author, but it is also the reality that health plans must collect sufficient premium to cover medical services. By preventing plans from making periodic adjustments based on legitimate actuarial factors, this bill simply ensures that individual consumers will receive bigger one-time premium increases, an issue that has been the focus of this committee at previous hearings. Thus, we fail to see how this benefits plan enrollees in any significant way. On the other hand, what this bill will do operationally for our plans, it will make it more difficult for our members to implement because it defines rates not just as premiums, but also captures other cost-sharing mechanisms like co-pays, deductibles, and out-of-pocket costs that are designed to make overall premiums more affordable for the consumer. Finally, our industry is working to understand and implement the most complicated healthcare reform measure passed in decades, and it will make significant changes to how the individual market will work. These changes include the enactment of a market exchange, the implementation of adjusted community rate standards, age variant standards, and other strict standards related to rates, including rate review. This committee will be debating these issues shortly. For instance, next week you are scheduled to hear a state-level exchange implementation bill that contemplates giving the state the authority over premium schedules, the collection of premiums, the administration of premium subsidies, and otherwise determine rates paid to participating health plans in that exchange. What if, when we embark on this totally changed landscape, the expected costs not match the reality? Flexibility will be required of participating plans or of an exchange administrator should there one be enacted. So advancing what we view as piecemeal legislation at this time, as we're trying to implement this major reform, we believe could be counterproductive. We do appreciate the author's willingness to work with us. We did have a constructive meeting. At that meeting, we outlined a number of issues and concerns that our members have. The bill in its current form does not reflect the concerns that we outlined, and so we remain opposed to the bill. Thank you.
Mr. Chair, members, Stephen Lindsay with the California Association of Health Underwriters. And I want to expand on something that's already been said, and that has to do with the psychological impact of a once-a-year rate increase. When somebody moves, and I'll use an example from a 50 age band to a 60 age band, we can see as much as a 10 or 15% rate increase just based on age. This bill prohibits that age increase during the year. And while we respect the author and appreciate the amendments that he has taken, our fear is that what happens is that every year we're going to get a 39% rate increase or a 27% rate increase because we don't ameliorate some of these legitimate actuarial factors that have been in the marketplace for years. Plans have always increased rates when somebody changed an age bracket. And we feel like that just stacks it all up so that once a year the folks in the individual marketplace who are the most price sensitive of any of the groups get hammered. And so we think that prevents or causes people to drop their coverage or prevents them from buying it. And we just don't think that's good for the marketplace.
Thank you. Other witnesses in opposition?
Jason Gabbard with the Association of California Life and Health Insurance Companies, opposed.
Manolo Platine, Blue Shield of California, opposed.
Dan Chick with HealthNet, opposed as well.
Angelica Gonzalez with Anthem Blue Cross, also in opposition.
Any other witnesses in opposition? Seeing none, committee member questions? Ms. Salas.
Yes, thank you. And actually, it's a question for the opposition. So if a spokesperson for the opposition could.
An able one right here.
The question that I have is that does this is primarily geared to the individual market and to the small group employers. Is that correct?
It's restricted to individual market.
Okay, so it's restricted to the individual market, but all of us that are covered under group insurance, we have an open enrollment period. And when we have that open enrollment period, we're expected to make choices about our coverage, how much we're going to pay for the premiums, and the price of the co-pays. all of that is defined within that open enrollment period. And when we make our choices in that open enrollment period, then we don't have the right to back out of that or change our mind within that year. So how would that be any different? How does that differ in the individual market when somebody says, I agree that I'm going to sign up for your health care insurance based on this premium cost per month, and I'm expected to get XYZ benefit for that premium dollar.
Right. Well, thank you for that question, Assemblymember Salas. I think one of the things that's important to understand about the individual market in California is that it's essentially a guarantee renewal market. In other words, unless, for instance, a person isn't paying their premium, that policy is renewed either month by month or a 6-month extension or by year. There is some variance in the industry. So the way some of my plans have described it to me, that there is a one-time, for lack of a better word, global increase that reflects the cost and utilization of medical and healthcare services, but that there may be necessary in the year to do a mid-year adjustment to capture some of the actuarial factors that we discussed in our testimony, some of which are reflected in amendments that the author has taken. And the purpose for that, again, is to ensure that those factors are accounted for as they arise, instead of essentially front-loading or back-loading them in one massive increase for the consumer.
But it would appear to me that some of those actuarials that you're basing your increases on is information that you would have known beforehand. For example, when you use the example of the person going from a 50-year-old age bracket to a 60-year-old age bracket, and that big increase in that, well, you know that going into the policy year to begin with. And so it seems to me that what's really important is for the consumer to be able to have some kind of confidence that when they enter into a contract with anybody or any industry, whether it be healthcare insurance or whether it be you name it, that a contract is honored for the time that it's entered to. And if you don't have the actuarials to support it at that time, then you shouldn't be striking a deal. So it just seems to me as a matter of fairness that a consumer is able to contract with a health care plan to have certainty. And I simply cannot wrap my arms around why that's not factored into the original contract.
Well, actually, the contract with the consumer contains all of those provisions. The rating that an individual gets is based on their age, their geographic location, and their family size. And if any one of those three things change, the rate needs to change to reflect that difference. Where, just as an example, if somebody moves from Sacramento to Southern California, their rate goes down. We have some of the highest rates in the state here in Sacramento. If somebody moves from Los Angeles to Mount Shasta, the actual underlying medical costs are different in those different regions. And that's all contained in the contract, which is available. And I mean, agents talk regularly to their clients about what goes into the rate setting, because that's a question we commonly get from our clients is, how do they set my rates? And it's based on your age, your family size, and your geography, and the individual marketplace. And those are the only three demographic things that we can use to set a rate in the individual marketplace. Now, there are some other costs that may change for a carrier because their renewals with their provider groups come at different times of the year. And so when somebody has an 80-20 plan, they may pay 20% on a different amount if the provider changed the rate in the renewal.
Yeah, which is already reflected in the amended version of the bill.
Thank you. Ms. Salas, further questions?
Well, I can understand the change in the family size, the change in the geographic area, but what I think is within your complete control is knowing that this person is going to get older. You know the age of that person. And so it seems to me that again, with the rate increases of insurance health plans just skyrocketing, I'm just wondering if the healthcare plan industry isn't afraid that they're going to put themselves out of business because consumers are just so afraid to enter into any kind of agreement with you because they can't rely on you.
Is that a comment,
I mean, they
Ms.
cannot.
Salas?
Yeah, it's a comment. You know, if you can't
Thank
rely on a contract, then what comfort level would you have as a consumer to enter into to any kind of business relationship with you? If you can't count on that, next month or the month after that, you're not going to be jacked up with 20, 30, 40% increase in your rate.
Well, that I'm afraid, remember that what the author is going after here, in many ways, does not reflect the significant rate increases that we've seen in the marketplace recently. These are increases that happen every year and have for the last 50 years. They're just a part of the ongoing underwriting and pricing policies in individual products, which are priced very, very differently than group products.
Thank you.
Yes, and just one last comment, and it's the same point that I made when we had the hearing about the Anthem Blue Cross rate increases. There's going to become a point in time where nobody can afford your product, and really, is that the end objective, is for you to get out of the individual market 100%.
Thank you, Ms. Salas. And Mr. Fuhr, thank you. Seeing no other committee member questions, I want to acknowledge what I understand the intent of this bill to be, which is to provide predictability during the course of that one-year contractual window. I want to applaud what I understand to be your work incorporating some of the concerns of the industry, and I do understand that you've accepted the technical amendment that's
Correct.
reflected in the analysis. Would you like to close, Mr. Fuhr?
I'd actually like to adopt the comments of Ms. Salas and the chair as my close and urge an aye vote.
Thank you. And we are still short of a quorum, so your bill will be on hold with others. Thank you very much,
Thank you, Mr.
Fuhr.
Chair. Colleagues, appreciate it very much.
I would ask members who may be listening on TV or remotely to please come and help us establish a quorum. I would call, we're going to go to item 10, Mr. Bell. I want to thank Assemblymember Cook for letting Mr. Bell step ahead. He has a number of witnesses here today. Thank you, Mr. Cook. I appreciate it. You are on deck. You'll be immediately following Mr. Bell's presentation here. Good afternoon, Mr. Bell. The floor is yours.
Thank you, members of the Health Committee, and I appreciate your time and your indulgence. This is AB 2173, the Emergency Air Medical Transportation Act, and it will provide for increased Medi-Cal funding of emergency air ambulance transportation by imposing a flat $3 fee on each motor vehicle violation in California, with the exception of parking tickets. The Medi-Cal rates for air ambulances have not increased since 1993. So that's quite a lengthy period of time of 18 years. This bill would increase the Medi-Cal payment rates and or provide supplemental payments to air ambulance providers by generating revenues which will be matched with federal funds from the State Department of Health Care Services. Air ambulance services provide life-saving emergency transportation for the most critical patients from accident scenes directly to trauma centers, and provide essential transportation to critical patients when ground transportation is not fast enough. Each provider serves a 100-mile radius and covers multiple counties. These critical service providers transport all emergency patients without knowing if the patient has any form of medical insurance or ability to pay for the service. The bill is supported by a wide range of emergency medical services providers, and air ambulance services are critical to the survival of our patients, and I ask for your aye vote. We have some witnesses.
Thank you, Mr. Bell. I was going to ask if you had any witnesses in support. Looks as though you might. Good afternoon to all of you. We'll go with 2 witnesses, 3 minutes each, and then we'll open the microphone for those of you here to testify in support.
They flew in just for this meeting.
They flew in just for this afternoon. Thank you, Mr. Bell. Please. Push.
There we go. My name is Bill Bryant. I'm representing California Association of Air Medical Services. Just to build on what Mr. Bell said, we do 3 kinds of transports. We transport patients directly from accident scenes. We don't control our own volume at all. We don't decide what flights we go on. It's usually the California Highway Patrol who arrives at a scene and determines if a helicopter is necessary or not. The second kind of transport we do is inter-facility transfers, where a patient presents themselves in a small rural hospital, and the physician there determines which are the most critical patients that need to go by air ambulance. Statistically, we probably go on helicopters are dispatched on about 2% of all transports in the state, as well as the country. We have no idea when we transport patients whether they have insurance or not. A great deal of them have no insurance and no ability to pay, and we simply eat that cost, absorb that, and have to turn around and charge enough money to other patients to collect that. We don't get tax support, with the exception of the city and county of Los Angeles, who has their own helicopters. The rest of the state is provided by private helicopters that must rely on patient revenue to offset the cost of doing business. And as you'll hear here in a second, it's quite an expensive endeavor. We also, unlike hospitals and physicians who also accept all patients, we don't get DISH money from the feds, and we don't get MADI funds that exist already. Both of those go to hospitals and emergency physicians, but none of that flows down to the air ambulances that transport those patients. So the bill, again, puts a $3 flat fee on moving violations. There's a natural nexus there. We do a lot of, preponderance of what we do, in fact, are motor vehicle related. And there's obviously a nexus between motor vehicle violations and accidents. Got the 1-minute warning. 94% of motor vehicle accidents, according to the CHP, are directly related to moving violations. This $3 fee gets sent to the state. The state gets a federal match of $2 for every $1 we put in. It's budget neutral to the state. It's budget neutral to the counties, and it'll augment and support the services. Thank you.
Good afternoon, Mr. Chairman, members of the Health Committee. Thank you for allowing us to speak. My name is Chris Giller. I'm the Chief Operating Officer for California Shock Trauma Air Rescue, also known as CalSTAR. We're a community-based, not-for-profit service covering 27 counties throughout Central and Northern California, as well as Northern Nevada and Southern Oregon. We currently operate 11 bases comprised of both helicopter and fixed-wing services. This is a very expensive operation, as you might imagine, with the fixed cost maintaining a 24/7/365 crew of highly trained experts in their field, both pilots, nurses, flight crew, and our maintenance technicians, as well as operate state-of-the-art helicopters to ensure maximum safety. Those items can run on the order of around $6 million for a state-of-the-art helicopter currently. This bill is very important to us because as Mr. Bryant and Mr. Bell have both indicated, a lot of our service has not, the reimbursement for our service has not kept pace with our fixed cost. We currently see, on average, about 1/3 of our actual hard costs in Medi-Cal reimbursement, which actually comprises 10% of our actual billed charges. We respond, as Mr. Bryant said, to all requests regardless of the ability to pay. We do not screen, and we come whenever we're called, very frankly. This service is not supported through any other means other than through commercial carriers or private pay, and so that is why your support in this bill is so very important to us. Thank you.
Thank you very much. Just before we go to the other witnesses in support, we're a couple shy of quorum. I would urge members of the Health Committee to come join us. We have members who are here to establish quorum, and we will expect those arrivals momentarily. Health Committee members, please hold your seats, and we will interrupt once we've established quorum. We will now turn to other witnesses in support. I would ask you to identify yourself by name and organizational affiliation. And I just want to advance, I see a lot of you here in uniform who provide this very important life-saving service. I want to thank you all in advance for your service. Please, would you like to begin by identifying yourself by name and organization? Thank you.
Mary Adams, PHI, or Medical Sonora-based manager, in favor of the bill.
Graham Pierce, Director for PHI in California, and in favor of the bill.
Mark Cassiopo, PHI, Central California.
Erin Cox, Metaflight, Flight Paramedic, Modesto Merced, and I support this bill.
I'm David Boyd from Metaflight, Flight Nurse, and work in Stanislaus and San Joaquin County and support the bill.
Lynn Malmstrom, Chief Executive Officer for CalSTAR. I support the bill.
Tara Stoddard from Sacramento with REACH, Flight Nurse, and I support the bill.
Patty Van Dyke, Flight Nurse and Clinical Educator, Yuba Sutter County, REACH Medical Services. I support this bill.
Don Campbell with Metaflight. We have bases in Merced and Modesto, and we serve 5 counties regularly: Mariposa, Stanislaus, San Joaquin, Merced, going up into the foothills. We request your support on this very important bill.
Chris Hall, PHI Air Medical, Northern California, serving numerous counties in Northern California. Thank you for support of this bill.
All right.
Troy Jones, Flight Paramedic, Base Medical Supervisor for PHI Air Medical in Redding, California, in support.
Angela Hurlburt, Flight Paramedic for PHI Air Medical in Redding, and I support this bill.
Lelania Hughes, Flight Nurse, PHI Air Medical, Redding, California, and I support this bill.
Sharita Lane with the California Children's Hospital Association in support of the bill.
My name is Timothy Stuczynski. I'm a flight paramedic with PHI Air Medical in Redding, California. I support this bill.
Tammy Allison. I'm a flight paramedic at PHI Redding, and I support this bill.
Lauren Thompson, Flight Nurse, PHI Air Medical in Modesto, and I support this bill.
Kathy Castro, Flight Nurse, PHI Modesto, and I support this bill.
Chris Arkson, PHI Air Medical, Modesto Base, and I support this bill.
Jeff Safely with CalSTAR, serving the Auburn and Sierra Nevada regions, and I support this bill.
I'm Roy Cox with Air Methods, supporting Mercy Air and Metaflight. We have 13 bases in California covering San Diego, Orange, Riverside, San Bernardino, Kern, Stanislaus, and Merced counties. And I'm a supporter of the bill.
Sean Russell, I'm the Chief Service Officer for REACH Air Medical Services. We have 13 bases in California, both in Northern and Southern California, and we support this bill.
Eric Freed with REACH Air Medical Services, Director of Service Delivery. We support this bill.
Larry Brown, REACH Air Medical Services, Sonoma and Lake Counties. I'm a flight paramedic, and I support this bill.
Tony Van Dyke, EMS pilot with REACH Air Medical Services in Yuba and Sutter County, in support.
Any other witnesses in support? Witnesses in opposition? Seeing none, committee member questions? Seeing none, Mr. Bell, would you like to close?
Yeah, I'd like to point out that there are 2 letters in opposition. However, I'd like to point out that some of the members that are servicing us in this are Teamsters, and I think it's important to recognize that these people do have organized labor as part of their background also. So there are members that serve in this capacity as Teamsters. I just wanted to point that out. I think this bill is needed. It's part of our emergency system. As you heard, they can't say no. They have to respond, and we can't have a system that doesn't fund our trauma care emergency services. It's a vital link to our system, and I urge and I vote on this bill, Mr. Chairman. Thank you.
Thank you, Mr. Bell. We are still without quorum. The bill will be on hold. Thank you all for being here this afternoon who came to testify on that bill. Now we will move to item number 4, AB 1976. Mr. Cook. Good afternoon, Mr. Cook, and the floor is yours at your ready.
Good afternoon, Mr. Chair. First of all, I want to thank Mr. Bell for having all these medevacs available for me. If things go south in this committee, I've been wounded twice in combat, and I can't say enough about they saved my life, and they might have to do it again here today. So, anyway, AB 1976 is similar to last year's AB 562, which many of you supported. I'd just like to remind everybody of the vote last year. We had 8 ayes, 3 noes. It failed. A number of people on this committee voted for it. Assembly members Jones, Conway, Fletcher, De La Torre, Adams, Emerson, Carter, and Nava. Just in case our memories have failed. This bill is actually hopefully better. This is a bill that will promote health care coverage. This bill will help ensure the best coverage.
Mr. Cook, I'm terribly sorry to interrupt right in the middle of your presentation, but we've just established a quorum, and it's been a very elusive objective.
They knew I was coming. That's why they waited.
If it's all right with you, I'll afford you whatever time you need. But if we could just take roll right now, I'd appreciate it. Thank you.
Monning.
Here.
Fletcher. Amiano. Carter. Conway. Brownlee. De Leon. Adams. Eng. Gaines. Hayashi. Hernandez. Jones. Lowenthal. Nava. Perez. Salas. Smythe. Strickland.
Quorum is established. Again, my apologies, Mr. Cook. Thank you. Please carry forward.
No problem. I failed to mention I have 126 witnesses available and standing by. I'm only kidding. This bill will help ensure the best coverage for employees. Many of you, same committee, stayed off of this bill last year because of some concerns, and we hope we have addressed those issues. Currently, the bill requires insurers to issue a report at the request of employers detailing the following: aggregate health insurance claims data broken down by month for a 12-month period. Provide a report and information on any individual claim in excess of $20,000, a large claim. Opposition to the bill focuses on the individual large claim report, the second requirement, stating that it violates privacy. In order to address these concerns, I propose removing the requirements for reports on individual claims in excess of $20,000. Instead, we propose amending the bill so that the employer only receives the number of claims made over $20,000. The employer would not receive any information as to the nature of these large claims, just that there were a certain number of claims over $20,000. There would be no individual information. They wouldn't even receive exact dollar amounts. Keep in mind that this bill really only applies to businesses with 51 or more employees. Any business below that number is quoted a generic group rate. These rates are open, available to the public, and can only fluctuate by 10%. While this threshold, of course, 51 employees or more is not explicit in the bill, we'd be happy to write it in if that is a concern. Small businesses need this business so that they can negotiate a fair rate. If a small business does not have 3 years of claim data, insurance will simply quote a book rate. As of today, small businesses cannot receive this data. Imagine that you as a driver go to an auto insurance with no record of your driving and accident history. With no information to prove that you are a safe driver, you are at the mercy in the rate quote. And small businesses are in a similar position. Large employers have access to claims data, both aggregate and large claims. Currently, insurers will provide this information to large businesses. If a large employer sees that their claim data has not changed much year to year and sees only a small amount of large claims, they might determine that they can self-insure, which will save them a great deal of money, and supplement that with catastrophic coverage, which covers them for large business or large claims. Small businesses do not have the same information, cannot make a determination if the rate offered to them is a good rate. With claims information, they might find self-insurance to be a viable option, or they might determine that their current insurer has increased overhead, even though their claim data has not changed much year to year. When rates increase for an employer, it affects everyone down the line. The President's health care reform is going to change that, requiring certain employees to provide coverage. This is the law of the land. Whether you agree with it or not, we are all sworn to uphold the law. With this in mind, we will do everything we can to provide small businesses with reasonable tools, which large businesses already enjoy, to help them negotiate a fair rate and comply with the law so that they may provide health coverage to the hardworking men and women in the state and their families. I have two witnesses. I really don't have 168 or what have you. I have Jeff Miles to my left, Health Insurance Professionals for Change, and I have Stephen Lindsay to my right, California Association of Health Underwriters. So if I could ask with the chair's permission.
Please. Thank you, Mr. Cook. Yes, please. Push your button there in front of you. There you go.
I'm Jeff Miles from Los Angeles, California, and as the author of this concept, I'm here to encourage you to please support this bill, Mr. Chairman and distinguished members. This is the first time we've actually had legislation that could potentially pass that might do something to generically lower the cost of health coverage. Please keep in mind that, as has been stated here on other bills already today, as health premium costs go up, employers are transferring that cost to their employees. Part of the reason for that is because they have no justification for the rates they're being quoted. They're never told whether or not they have a lot of claims, few claims. They're just given a renewal action and told, sorry, that's all you're going to get. As those premiums go up, those employers are either cutting back the coverage, they stop hiring because they can no longer afford the premiums, and employees voluntarily drop out of the plans because they can no longer afford their contribution. Think of it, if you were an employee who made $30,000 a year and you're currently being covered by your employer, but you have to pay $300 a month to cover your family, and all of a sudden they come along and say to you, well, now it's $500 to cover your family. If you have a fixed income, meaning you're working for a company, you're not getting any pay increases because of the economy, you simply cannot afford that level of increase in premium. This bill will finally do something to force the insurers to play fair with their employer clients in the mid-sized market. They're already forced to do so by competition in the large employer market. And the small group market, as has already been mentioned here, between 2 and 50, is already regulated with compressed rates. So the marketplace that needs this help desperately is the employer groups of 51 to as much as 1,000 employees who are paying the highest rates in the state without any justification for the reason why. So I'm available for your questions. Thank you very much for the opportunity to talk to you today.
Mr. Chair, members of the committee, currently in California, 35 to 40% of the insured individuals are insured in self-insured plans. CalPERS is one of the biggest in the state. Those employers who are self-insured currently have access to not only the data that we have requested, but they have access to all of the data. And so what we're doing, if you do not allow these mid-sized groups to have this data, you put them at a serious competitive disadvantage with their larger employers. That means that they have to pay more for health insurance. It means it's harder for them to continue to provide insurance. Currently, carriers use this same data. So if I'm insured by Blue Shield and I'm in the mid-market, Blue Shield already has this data. They know what my claims are. They know what the claims over 20 or 50 or whatever number thousand of dollars you set. They know what the diagnostic codes are because they've paid all the claims. And so what, in effect, you're saying is that we only want one carrier to have this data in order to price their product, but we don't want another carrier over here to have that same data in order to see if they can give this employer a better price. Well, I know that there have historically been privacy concerns around this data. What I would suggest to you is that not only does California insurance law allow the employer specifically to have that data, that HIPAA actually has specific sections that allow the employer access to that data. And so this is an issue that has been vetted at the federal level. My trade association, which has almost without exception supported every increase in privacy requirements in the state of California, truly understands the need to keep that information in the circle of trust. So all of the folks who have that data have not only statutes and regulations that regulate them, but they're bound by all of those to not release that data to unauthorized individuals. So this data only goes from one carrier who's authorized to have it to another carrier that also is authorized to have it. And so I request your aye vote.
Thank you. Other witnesses in support? Seeing none witnesses in opposition, please step forward. We'll allow testimony from 2 witnesses and an identification of others. Please do identify yourself for the record.
Jason Gaphardt with the Association of California Life and Health Insurance Companies. One of our main concerns in opposition of the bill was the individual information being reported. However, we just learned about those proposed amendments today, so we will have to go back and have our members take a look at that. However, we still are opposed to the bill because we're afraid that it might be difficult to report this information that would be requested within the 30-day timeline. Will be inundated with requests. And if we don't meet that timeline, that we would be subject to basically right now an unfair administrative penalty by the Department of Insurance. Thank you.
Valerie Small Navarro with the American Civil Liberties Union, and we appreciate the effort the author has made to address the privacy concerns. I think we still have some remaining concerns, and I would like to continue working with the author's office. I think, though, that people should consider that this idea that it's only going to apply where there's 51 employees or above does not address privacy concerns. I mean, I think any employer who has 51 employees and gets a bill or knows that an individual has claimed more than $20,000 could probably fairly easily figure out which employee or employees' children or dependents have filed those claims. And I think in this economy, it's even more important that we protect individuals' privacy. The threat of being fired looms pretty large out there, and even though we have protections against being fired because of medical issues, I think it's not a stretch to see that happen. So I still suggest that there's considerable issues that need to be dealt with. Thank you.
Thank you. Other witnesses in opposition?
Thank you, Mr. Chair and members. Nick Luizos, California Association of Health Plans, in opposition.
Dan Chick with HealthNet in opposition. We're going to take a look at these amendments. We haven't had time to review them. Thank you.
Any other witnesses in opposition? Seeing none, committee member questions? Mr. Adams.
Thank you, Mr. Chairman. I too actually had concerns about the privacy issues. I do think that this bill goes a long way towards addressing those. I share the ACLU's concern that in a group of 51 it may be possible to identify, but I also believe that the weighted balance of the remedy that exists at law to protect people against that type of abuse is sufficient to necessitate the promulgation of good public policy, and I think that what this bill seeks to do is achieve good public policy by way of ensuring that rates are reasonable and fair and balanced, and for that reason I'd be happy to support the bill.
Any other questions or comments? Mr. Cook, I'll just share on the record what we've shared in our conversations. I also applaud your efforts to try to address some of the concerns about the privacy issues. I expressed with you my concern, even with the proposed amendments, of an inappropriate access by employers to identification of an employee who may access the benefits of that plan. That's counterbalanced, I know, by your intent of creating an economic level playing field for purposes of negotiating these contracts. But with those concerns expressed, I would invite you to make your close to the committee.
Thank you, Mr. Chair, and I appreciate you giving me a very, very fair hearing on this. You know, on this type of bill, it's almost damned if you do and damned if you don't, because part of it is to get that ground in the middle where you can provide that economic fair playing field, if you will, so that businesses, particularly even though they might have, you know, 100, 200 people, are considered small businesses and hanging on by their fingernails. And the issue, I think one of the big issues, of course, is the protection for the employees. If the employees are out of work because the company is no longer in existence, the issue becomes almost moot. I do submit to you that we are very, very sensitive to what we call a firewall. And the firewall is and very, very open to any amendments or suggestions to keep this bill alive, where we had this protection, how we had it written in there, and greater minds than mine are on this panel here with much more expertise to ensure that the individual employees are protected so that, one, they have a job, two, that they are not fired for having a catastrophic illness or a long-term illness. I shared with the chair, and I think many people know that I've been around the block on this with leukemia, and sometimes you can't even get insurance once you've been diagnosed with it. And I really, really am very, very sensitive to that issue because of the unfairness of that. And somebody that has an illness and gets fired for that, I think is just horrible. And that's why I'm trying to, obviously, the purpose of the bill is to get an environment to have these companies survive, if you will. They're not the large dogs and not the very, very small ones, but they're the ones that at the mercy of the economy right now. And the only thing is, we're going to continue to, if this dies today, and I don't know if it will, the only thing I'd like to add that last year we came very, very close to passing this bill. And I guess there's a new cliche that I could say, and that close only counts in horseshoes, hand grenades in the Assembly Health Committee. So I ask for your indulgence, your suggestions to help this bill along, which I think will go a long way in the industry, and I ask for your aye vote. Thank you.
Thank you, Mr. Cook.
Mr. Chair, I move the bill.
We have a motion.
Second.
And a second. This motion do pass and refer to Judiciary Committee. Please call the roll.
Monning?
No.
Monning, no. Fletcher? Amiano? Carter? Carter, aye. Conway? Brownlee? De Leon? Adams? Aye. Adams, aye. Eng? Gaines? Aye. Gaines, aye. Hayashi? Hernandez? Jones? Lowenthal? Nava? Perez? No. Perez, no. Salas? Not voting. Smythe? Aye. Smythe, aye. Strickland?
Okay, that has 4, needs 2 more, needs 6 more, I'm sorry. It is on hold. Thank you, Mr. Cook, for your work on this issue. It's on call. Thank you. Mr. Chesbro, please come forward. We'll go first to item number 12, AB 2268.
Thank you, Mr. Chairman.
Mr. Chairman, I move the bill.
We have a motion and a second. Thank you. Mr. Chesbro.
Okay, well, I had to make it really brief then, it looks like. But accept the committee's amendments in the analysis, which help to more clearly address the issue in the statute. This bill will align California statute with federal law that specifies who may prescribe and treat drug addiction with the approved forms of buprenorphine. I always want to say ibuprofen, but buprenorphine. I have with me today the sponsor of the bill and representatives of the Department of Alcohol and Drug Programs to testify.
Thank you, Mr. Chesbro. Please present your witnesses.
Good afternoon, Chairman Monning and members. I'm Tina Chigensky, representing the Department of Alcohol and Drug Programs, and I have Dr. Dr. McCants. She's our medical director to testify in support of the bill. Thank you.
I am Eleanor McCants-Katz. I'm the State Medical Director for California Alcohol and Drug Programs. I'm a licensed physician in California and a board-certified addiction psychiatrist. This bill was written to correct a problem in current California law which does not allow qualified physicians to treat opioid dependence in their office-based practices unless both they and the patients they so treat are registered with a licensed narcotic treatment program. This is in direct opposition to current federal law and is counter to the laws and regulations regarding this practice in the rest of the United States. By addressing the gap between California law and federal law, this bill will serve three valuable functions. It will protect from potential prosecution over 1,200 California physicians who are federally certified to treat patients for opioid dependence in their private practices. It will ensure their ability to serve the many individuals who need opioid addiction treatment, and it will greatly expand treatment capacity by utilizing private physicians in the community. I would like to emphasize that there are no publicly funded costs associated with this legislation. It is simply intended to correct an inadvertent legal gap. The Federal Drug Abuse Treatment Act of 2000 permits qualified physicians to engage in office-based treatment of opioid dependence using drugs specifically approved by the U.S. FDA on Schedules 3, 4, and 5 or combinations of such drugs. This legislation was followed by FDA approval of buprenorphine naloxone and buprenorphine tablets, both Schedule 3 medications for the treatment of opioid dependence in October 2002. At that time, there was an attempt to modify existing law to permit licensed narcotic treatment programs in California to also offer this treatment. Inadvertently, a change was made that required all physicians in California offering office-based treatment of opioid dependence to be affiliated with a licensed narcotic treatment program, and similarly that patients receiving this treatment also be enrolled in these programs. Such a requirement reduces access to care, as most physicians are not affiliated with narcotic treatment programs since this is not their primary practice, nor are they likely to be so affiliated. Furthermore, many areas of California lack narcotic treatment programs. In addition, one of the primary benefits of prescribing buprenorphine is that it takes place in a private physician office, thus reducing the stigma of seeking treatment and attracting patients who might not otherwise receive treatment, including women and adolescents. I also want to make it clear that the proposed statutory change in AB 2268 will not permit physicians to prescribe methadone from their office-based practices for opioid addiction. Dated 2000, and the proposed changes in AB 2268 would only allow medications specifically approved for the treatment of opiate addiction in Schedules 3, 4, and 5 to be prescribed from office-based treatment. Methadone, a Schedule II drug, can only be administered by narcotic treatment programs, and this will not change. Thank you very much, and I hope you'll be able to support this bill.
Thank you. Other witnesses in support?
Randall Hager, representing the California Psychiatric Association. We urge your support.
Dr. Christy Waters from the California Society of Addiction Medicine, over 400 physicians who specialize in the treatment of substance abuse, and we also urge your support.
Tom Renfrey with the County Alcohol and Drug Program Administrators in support.
Thank you. Other witnesses in support? Yes.
Nicole Wertelman on behalf of the City and County of San Francisco in support.
Thank you. Any other witnesses in support? Seeing none, any witnesses in opposition? Seeing none, committee member questions? Seeing none, Mr. Chesbro, I'd invite you to close.
Mr. Chair, this bill will remove ambiguity and eliminate the legal risk that is currently present for the 1,200 qualified physicians who are providing this treatment in office-based settings. I urge your aye vote.
Thank you. We do have a motion do pass as amended by Mr. Adams, seconded by Mr. Hernandez. Would you please call the roll?
Monning?
Aye.
Monning, aye. Fletcher? Amiano? Carter? Carter, aye. Conway? Brownlee? De Leon? Adams? Adams, aye. Eng? Eng, aye. Gaines? Hayashi? Hayashi, aye. Hernandez? Hernandez, aye. Jones? Lowenthal? Nava? Perez? Perez, aye. Salas? Salas, aye. Smythe? Smythe, aye. Strickland? Lowenthal? Lowenthal, aye.
That has 10. The bill is out.
Thank you very much, Mr.
Thank you. Mr. Chesbro, you'll hold your position there as we move to item 14, AB 2586.
Yes, Mr. Chair, members. First, I would like to accept the committee's recommended technical amendments listed on page 6 of your analysis. AB 2586 is a simple measure that will bring more accountability and transparency to health insurer provided networks to help ensure that patients can access a health care provider when they need one. The bill has 3 key provisions. One, it requires health plans and insurers who are undertaking substantial changes to their provider networks that impact more than 2,000 enrollees and could impact access to care that they must demonstrate to the regulator prior to making the change that they still have an adequate provider network. 2, it provides the accuracy of provider directories, improves the accuracy of provider directories by explicitly prohibiting plans and insurers from listing providers who are deceased, retired, non-contracted, or out of network, and it requires provider directories that are posted on the internet to be updated at least quarterly. And then third, it requires the Department of Managed Health Care to review compliance with current network adequacy standards in its periodic on-site medical review of health plans as required by existing law. Last year, Blue Cross canceled contracts statewide with 53,000 physicians who serve healthy family kids with the intent of recontracting with some of them at significantly reduced rates. Understandably, many of these physicians refused to sign these new contracts, given that their rates would be slashed by 50% or more. And as a result, thousands of kids in my district and thousands more in at least 14 other rural counties where access is already a problem for these kids were at risk of not having a doctor to care for them. Members, I agreed to carry this bill because of the chaos experienced by the families in my district who found it impossible to access health care as a result of the Blue Cross so-called network redesign. Enrollees were never notified of the change, and DMHC and Mr. Mibb, who I have met with on this issue, are still scrambling to try to pick up the pieces. Ironically, when DMHC asked Blue Cross to prove that there was still a network in place, they presented the old provider directory that still listed all the physicians that they had just terminated contracts with, not to mention dozens of other errors. Nearly a year later, we have not seen an updated Blue Cross provider directory, which is not surprising since to do so would reveal a decimated network. There are numerous other examples of this occurring throughout California, and we suspect that this tactic will only increase as health plans look for new ways to increase profits by forcing providers to accept disproportionately large reductions in their reimbursement rates. With this bill, we are hoping to get out ahead of the problem. This bill is sponsored by CMA and supported by the American College of Emergency Physicians, the California Dental Association, the California Chiropractic Association, the California Hospital Association, California Psychological Association, Children Now, Health Access, and the California Association of Marriage and Family Therapists. I have Teresa Stark here to testify on the bill and to answer your questions.
We have a motion from Mr. Perez. Is there a second? Second from Ms. Carter. Thank you.
Thank you, Mr. Chair and members. Teresa Stark with the California Medical Association. Very pleased to be the sponsor of this measure, and we thank Assemblyman Chesbro for his leadership on the issue. CMA did not arrive lightly or easily at the decision to sponsor this bill. After getting numerous complaints from our member physicians about the Blue Cross recontracting initiative, we began to look into it, and our staff struggled for months to understand how this debacle had happened. We tried to resolve it with Blue Cross. We were unsuccessful. We've been communicating regularly with DMHC staff. to alert them to the problem and to try to figure out how this had happened and why current law was not sufficient to prevent it. Eventually, it became clear that a bill was necessary to prevent these kinds of future network modifications to make sure that we don't negatively impact enrollees and we can minimize the disruption if there are contract changes to this of this nature. The problem of inaccurate provider directories and inadequate networks is not a new one. This legislature is very familiar. Nearly everyone has a story about trying to find a doctor and having to make dozens of phone calls before they are able to find one. The legislature and the Department of Managed Healthcare have been working for years, and we have a lot of good laws on the books. We don't create any new requirements here today when it comes to network adequacy or ratios. This bill simply fills in a few loopholes because the provider directories are what the plans are using to demonstrate adequate networks, and they are wrong. You would think we wouldn't actually have to spell out that you can't put a deceased physician or a retired physician on your directory, but we keep hearing about that as a problem. So we wanted to make it very specific in the law that you can't do that. With respect to out-of-network or non-contracted providers, that is a terrible situation if a patient goes to a physician who is not even in their network. It can be awkward and uncomfortable for both. It can result in medical debt for the consumer and a lot of emotional stress. So basically, members, this bill just ensures that you get what you pay for. When you need a doctor and you refer to your provider directory, you have a reasonable expectation that that directory is current and accurate. It's the health insurer's responsibility to keep these lists accurate. That's what they do. That's why they exist. When you're shopping for health insurance, the provider directory is what you use to make the decision, and it's relevant. By posting directories that list providers who are not accessible to patients, health plans and insurers are falsely marketing a non-existent network. It's false advertising, it misleads patients, and it misleads the regulators. And I just want to briefly, I have a visual aid today, briefly show you, we pulled up Anthem's provider directory that they have for healthy families in Humboldt County as one example. And I just want to page through here. All of the highlighted names of doctors are all of the mistakes. Either they are listed at incorrect addresses, they are no longer practicing in the area, they are retired. There is a deceased physician on here. We have physicians listed who are only treating veterans. And if this is a Healthy Families Network, I'm not sure how that's relevant. Osteoporosis specialists.
Thank you, Ms.
For
Stark.
children. So this gives you an idea, and I'm happy to do this for any member. If you'd like us, our County Medical Society, to go through the provider directory for Healthy Families or any product in your area and look at the provider directories, we're also happy to do that for you. So we urge your support today.
Thank you very much. Other witnesses in support?
Yes, David Vandergriff on behalf of the California Hospital Association in support.
Mr. Chair and members, Monica Miller representing the California Chiropractic Association in support. Thank you.
Mr. Chair and members, Tim Madden representing the California chapter of the American College of Emergency Physicians in support. Thank you.
Other witnesses in support? Seeing none, I'm sorry, go ahead.
Beth Capel for Health Access, also in support.
Thank you.
Mr. Chair, members, Fred Notware with the California Dental Association in support. Thank you.
Amanda Levy, California Psychological Association in support.
Tim Shannon, California Association of Marriage and Family Therapists, and the California Orthopedic Association in support.
Crystal Moreno-Lee with Children Now in support.
Thank you. Any other witnesses in support? Seeing none, witnesses in opposition?
Mr. Chair, members, Jim Gross on behalf of the Local Health Plans of California, which are the public plans in counties such as San Bernardino, Riverside, Los Angeles, Alameda, and also a plan in San Diego, all of which do Medi-Cal and Healthy Families. What I heard from the witnesses on this bill is it was making simple corrections. It was dealing with issues evidently associated with one particular plan that pulled out of a particular area. Now, I would like to just briefly go through a couple of provisions of the bill and show you how this bill is, in effect, a catch-22 for any health plan. This bill adds to the requirements of what should be on the list of providers hospital-based physicians. The list should also include the specialty of each of these physicians. Now, as many of you know, a hospital-based physician may not, often is not, contracted with the health plan. So we don't necessarily have a way to easily find out who is a hospital-based physician at a hospital we contract with. Also, we have to be able to disclose the credentials of that individual. Again, not easy to determine. The list shall indicate which providers have closed practices or otherwise not accepting new patients. Change the law. It used to be who have notified the plan. Now they don't have to notify us, but we have to know. And somehow they're going to indicate to us. The bill uses the term indicate numerous times. I'm not sure exactly what indicate means here for purposes of our obligation. It does add a provision that subjects us to civil penalties for violations of any of these provisions, which includes listing any non-contracting provider. Here's where the problem comes in, the second part of the bill. In order to be able to change your network, you must get approval from the Department of Managed Healthcare, and you must give notice to the provider who is going to be coming off the network, including if the provider, him or herself, terminated with you. So if one provider, a specialist, decides not to continue to provide Medi-Cal, and that specialist is needed, based on the formula in here, to serve 2,000 patients, I can't have that individual on my provider list anymore, but I can't take that provider off my list until I give him notice and wait for the Department of Managed Healthcare to tell me it's okay. So chances are, given the timelines, we'll be in violation of the first part of the bill and be subject to civil penalties because we're waiting for the Department of Managed Healthcare to tell it's all right to take a provider off who terminated with us. And in fact, what you'll find out is the majority of terminations are in fact as a result of the provider terminating. In addition, we have to deal with renegotiations. We have to notify the department when we've actually renegotiated a contract. So this bill may be simple, but Mr. Chesbro, who's been a good friend to the plans to provide services for healthy families in Medi-Cal, I don't think he understands that what he is guaranteeing is that these plans will violate the law, and that in doing so, they will be fined. Now, the other alternative is that, of course, they never, ever will terminate a provider again. So I think you need to think about what the impact is on a much broader cross-section of plans that are providing these services and doing what you've asked them to do by law. Thank you.
Mr. Chair, since I've been accused of not understanding my bill, may I respond to a couple of points?
Let's get the one other witness, and you might be able to respond to both. I think
there are some serious inaccuracies in the statement that was just made.
In opposition.
Thank you, Mr. Chair and members. Nick Luizos with the California Association of Health Plans. And when you take an even closer look at the bill, its more onerous aspects become even more evident. The bill not only requires approval for a network modification involving even one provider from the Department of Managed Healthcare, which regulates HMOs, it also adds this requirement on the Department of Insurance side that regulates PPOs. So in effect, if you have a contract with a provider that is on contract with you for both your HMO business and your PPO business, you essentially need approval from both regulators in order to terminate this one contract, even if the contract termination was initiated by the doctor or the hospital. So, you know, we're scratching our heads to figure out how that will work. What if the two regulators come to different decisions? What if their timing is off from each other? Those answers aren't addressed in this bill at all. The bill is fraught with problems and inconsistencies as outlined by LHPC. It sets in motion a costly and timely bureaucratic approval process for modifications impacting only one provider, again, whether the provider initiated that contract termination or not. We don't believe that more filing and oversight over network management does anything with respect to access to health care in rural areas. It certainly doesn't impact the problem of underfunding of public programs, which our plans participate in quite extensively. We already do, in fact, have a high regulatory standard when it comes to provider networks, both at the licensure stage of a plan being able to enter into the business and with respect to large-scale changes when a large group of enrollees need to be assigned from a provider group or hospital to another due to network modifications. So we just think this bill means more precious resources dedicated to admin and not to patient care, and we urge your no vote. Thank you.
Thank you. Let's get other witnesses in opposition for the record, and then Mr. Chesbro, you can respond to those concerns. Yes, others in opposition.
Very good. Thank you, Mr. Chair. Manolo Platine, Blue Shield of California, in opposition.
Jason Gapart with the Association of California Life and Health Insurance Companies in opposition.
Dan Chick with HealthNet in opposition.
Maureen O'Haron representing Molina Healthcare of California in opposition.
Maureen Higgins, representing America's Health Insurance Plans in opposition.
Seeing no other witnesses in opposition, Mr. Chesbro, would you like to respond to the concerns raised, and then we'll open it to committee members?
Well, first of all, let me remind you that we're simply saying that if you're going to take public dollars or dollars from a patient under the guise of having available physicians in a community, you got to have those physicians available in the community. With regards to some of the specific points that were made, there really aren't any physicians that I am aware of that have 2,000 enrollees. Let me call your attention to line 15 on page 6. For purposes of this section, network modification means a change to network contracted healthcare providers where the change would affect more than 2,000 enrollees by reducing the number of contracted physicians in the service area, or by terminating, renegotiating, or otherwise impacting a provider contract in the network. With regards to whether or not they have to list hospital-based physicians that are not contracted, I don't know what language Mr. Gross is looking at, but line 3 of page 3 of the bill, a healthcare service plan shall provide, upon request, a list of the following contracting providers, followed by the 5 categories, actually 6 categories, the 5th one being hospital-based physicians. So it would be hospital-based physicians who are contracting providers. There are other points, if you don't mind, if I could have the sponsor address.
Mr. Chair, could I correct one thing that Mr. Chair, as a matter of how the bill actually works? On the 2,000 issue, it's not a question of whether a physician has enrollees. Physicians don't even have enrollees, they have patients. What your bill says is that if the change affects 2,000 enrollees of the plan, a specialist may, in fact, pursuant to the Department of Managed Healthcare determinations, a specialist may be in the network because you need that specialist to cover that number of enrollees, which easily could be 2,000. And so taking one specialist out could, in fact, trigger that. It doesn't have anything to do with how many patients that individual sees.
Thank you, Mr. Gross. Ms. Stark.
Exactly, Mr. Chair. I appreciate Mr. Gross making our point for us. If you remove a specialist, especially in some of these rural counties where access is already a problem, you remove one specialist that takes care of 2,000 patients, you want to make sure that those patients have somewhere else to go. And that's all we're saying. If they're going to modify their network, redesign their network, disaffiliate, whatever they want to call it, we want to make sure that those patients, their arrangements made. Now, it's already current law. They have to do this in a case of a block transfer. That's already current law, and that's what we're modeling this after, because current law did not cover this situation because they were not referring to it as contract termination. They used all sorts of other language, a disaffiliation or redesign or recontract, and they were able to skirt around the block transfer requirements. So that's really important. With respect to the language that we initially did strike in the bill, where it was not clear any longer that the physician would have to let the plan know if their information changed, we took a technical amendment recommended by the committee to clarify that. That is going back in the bill. And I want to challenge Mr. Gross's assertion. The way the bill is written is if it's a health plan undertaking a network modification, then those requirements kick in. It doesn't apply if a physician is undertaking the contract termination. All they have to do, even if it's one specialist, all they have to do is go to the department and say, Dr. So-and-so is no longer going to be contracted with us. However, we are sitting down, we're negotiating in good faith with his colleague down the street. We believe that he will negotiate with us. We have the network under control. We'd appreciate your approval. It's not rocket science. It should be very simple.
Thank you, Ms. Stark. Committee members, questions or comments? Mr. Adams?
Thank you very much, Mr. Chairman. Mr. Chesbro, actually, I understand, at least I believe I understand what it is you're trying to achieve and actually think it's laudable. Like you and some of your witnesses, I'm frustrated oftentimes by looking at my networks and determining that the people that we want to have are not actually there, or the people that were going to be convenient for us aren't available. But I do have substantive concerns with the private right of action. This is the part I think is the most frustrating for me. The idea that a mistake or a failure to have absolutely up-to-date, accurate information at all times can result in, the insurance company being taken to court and have civil penalties assigned to them is I think, frankly, it seems a little overbearing. And I wonder if you're in any way at least amenable to the idea of working with the opposition on the private right of action concerns, because otherwise I think the bill has, a great deal of merit.
I want to point out that the private right of action only applies to that one subdivision in the bill, not to all of the provisions of the bill. So you may still object. You may still object to the.
Sure, but could a private right of action occur by virtue of having misinformation on the network list?
I think that issue has been brought up, and we're certainly, if there's an error, we certainly want to give the health plan a fair and reasonable opportunity to correct that. So one of the things we've been throwing out is if that error hasn't been corrected within the 90-day quarterly update requirement, then they're subject to a lawsuit. But once again, if they're not listing out-of-network or non-contracted providers, then nobody's going to sue anybody. But we want to be able to work with the plans on narrowing that language to make sure that if it is an error or an honest mistake, if they've had 90 days to fix it and they have not done so, but we're certainly willing to work with you, Mr. Adams. We understand that that is a concern, and we can keep talking about that.
Mr. Chairman, that language doesn't currently exist either in mock-up form or in the bill itself, but I think it would be a necessary function of making sure that we're allowing both actors in this to operate in good faith.
Thank you, Mr. Adams.
May I give one more comment?
Please,
in response
Mr.
to Mr. Adams, and that is that the underlying premise here is that it's a concern about false advertising and unfair business practices, and private right of action for that kind of cause is not unprecedented. Thank you.
Mr. Chesbro, my understanding is you have accepted the amendments listed on page 6 in the analysis, and also I'd like you to address your commitment on taking amendments to delete the interactive website requirement. Is that accurate?
Yes, I'm committed to taking that.
Thank you. And seeing no other questions, would you like to close, Mr. Chesbro?
Well, after hearing from my good friend, Mr. Gross, and the other health plan opposition, it's as if they're talking about a completely different and far more onerous bill than I have brought before you today. To be perfectly clear, AB 2586 simply will require that network directories are accurate and up to date, that if a provider network is substantially modified, where more than 2,000 enrollees are impacted, the insurer must demonstrate to the regulator prior to making the change that there will be an adequate provider network, and finally that there's an insurance that the plan's compliance with current network adequacy standards during its periodic on-site medical review. Now think about it. Taking state or private money to pay for health care and not through an insurance plan and not having adequate providers, quite frankly, is fraud and ought to be prohibited. This is short of that. It's simpler. It just simply requires that there be an up-to-date and accurate list. My bill is a common-sense approach that will ensure that Californians get the services that either they've paid for or the taxpayers have paid for. So I would urge your aye vote.
Thank you, Mr. Chesbro. We have a motion by Mr. Perez, a second by Ms. Carter. Would you call the roll, please? This is due pass as amended to appropriations.
Monning?
Aye.
Monning, aye. Fletcher? No. Fletcher, no. Amiano? Carter? Carter, aye. Conway? Brownlee? De Leon? Adams? Eng? Eng, aye. Gaines? Hayashi? Hayashi, aye. Hernandez? Jones? Lowenthal? Lowenthal, aye. Nava? Perez? Perez, aye. Salas? Smythe? Smythe, no. Strickland?
It has 6 votes, needs 4 more. It'll be on hold. Mr. Chesbro, your third bill of the day, item 15, AB 2675.
Hopefully mildly less contentious and quicker.
Mr. Chairman, I move the bill.
A motion from Mr. Adams, second by Mr. Smythe. Please proceed.
I'll let my witness talk and then ask for your aye vote. It sounds like I've got the support here. So unless anyone has any questions or concerns.
Dave Helms, and on behalf of the California Association of Health Facilities, urge your support for this fine measure. Thank you very much.
Thank you. Any other witnesses in support? Any witnesses in opposition? Questions? Seeing no questions, it's been moved and seconded. This is a motion due pass. Please call the roll. This is due pass 2 appropriations.
Monning?
Aye.
Monning, aye. Fletcher?
Aye.
Fletcher, I. Amiano. Carter. Carter, I. Conway. Conway, I. Brownlee. De Leon. Adams. Adams, I. Ing. Ing, I. Gaines. Hayashi. Hayashi, I. Hernandez. Hernandez, I. Jones. Lowenthal. Lowenthal, I. Nava. Perez. Perez, I. Salas. Smythe. Smythe, I. Strickland.
That has 11 votes. That's out. Thank you, Mr. Chesbro.
Thank you, Mr. Chair and members, for your kind consideration.
Mr. Liu, with your indulgence, we're just going to move the consent calendar, and then we'll get right to you. Do I have a motion? Mr. Adams, second. Mr. Smythe, second. This is on the consent calendar, AB 1931, AB 2248. Please call the roll.
Monning.
Aye.
Monning, I. Fletcher.
Aye.
Fletcher, I. Amiano. Carter. Consent calendar.
Consent.
Consent calendar. Aye.
Carter, I. Conway. Conway, I. Brownlee. De Leon. Adams. Adams, I. Eng. Eng, I. Gaines. Hayashi. Hayashi, I. Hernandez. Jones. Lowenthal. Lowenthal, I. Nava. Perez. Perez, I. Salas. Smythe. Smythe, I. Strickland. That's 10.
That has 10. Consent calendar is out. We're now moving to item number 9, AB 2153. Mr. Liu, good afternoon.
Thank you. This bill would improve emergency room overcrowding by requiring all California hospitals to create and implement a full capacity protocol plan. This is modeled on legislation in New York. All of you voted yes on this bill on concurrence. It was unanimous. Exactly the same bill. Governor vetoed it, but now we're going to work with the governor with this veto message and craft a bill for which we'll hopefully get a signature. Respectfully request an aye vote.
Mr. Chairman, I move the bill.
We have a motion and a second. Witnesses in support.
Tim Madden, representing the California chapter of the American College of Emergency Physicians. We are the sponsor of this legislation. As Mr. Liu mentioned, it is the same as you had voted on last year, and given the direction of the committee, I will hold my comments here and answer any questions if needed. Thank you.
Thank you, Mr. Chair, members of the committee. Carolyn Jenno with the California Medical Association in support of the bill. Thank you.
Thank you. Other witnesses in support? Any witnesses in opposition? Seeing none, committee members, any questions, comments? Mr. Liu, would you like to close?
Respectfully request an aye vote.
Thank you. We have a motion by Mr. Smythe, second by Mr. Adams. This is due pass and refer to appropriations. Call the roll, please.
Monning.
Aye.
Monning, I. Fletcher.
Aye.
Fletcher, I. Amiano. Carter. Carter, I. Conway. Conway, I. Brownlee. De Leon. Adams. Adams, I. Eng. Eng, I. Gaines. Hayashi. Hayashi, I. Hernandez. Jones. Lowenthal. Lowenthal, I. Nava. Perez. Salas. Smythe. Smythe, I. Strickland.
It's fine.
That has 9. Mr. Liu needs one more. Thank you. We'll hold that. Okay, members, just a time check here. We're waiting for Ms. Salas, who will be presenting for Mr. Torrico on item 13, AB 2456. Maybe while we're waiting for her arrival, we could move through some votes on items for which we have not yet taken votes.
Mr. Chair, I'd like to move item 2, AB 1916 by Mr. Davis.
Okay. Thank you. We have a motion from Mr. Adams on item 2. Could we start with item number 1, AB 1759? Is there a motion? That's Mr. Blumenfield's bill. Ms. Lowenthal, Ms. Carter, anyone want to move Mr. Blumenfield's bill? This is item 1. We have a motion from Ms. Lowenthal, second from Mr. Eng. Please call the roll. This is due pass as amended.
Monning?
Aye.
Monning, aye. Fletcher? Fletcher, no. Amiano? Carter? Carter, aye. Conway? Conway, no. Brownlee? Brownlee, aye. De Leon? Adams?
No.
Adams, no. Eng? Eng, aye. Gaines? Hayashi? Hernandez? Jones? Lowenthal? Lowenthal, aye. Nava? Perez? Salas? Smythe? Smythe, no. Strickland?
That has 5, needs 5 more. Let's move to item 2, AB 1916.
So moved.
Mr. Davis, we have a motion from Mr. Adams. Is there a second? I will second that. This is due pass to business and professions. With amendments to be taken at business and professions. Would you call the roll, please?
Monning?
Aye.
Monning, aye. Fletcher?
No.
Fletcher, no. Amiano? Carter? Carter, aye. Conway? Conway, no. Brownlee? Brownlee, aye. De Leon? Adams?
Aye.
Adams, aye. Eng? Eng, aye. Gaines? Hayashi? Hayashi, aye. Hernandez? Jones? Lowenthal? Lowenthal, aye. Nava? Perez? Salas? Smythe? Smythe, no. Strickland? Strickland, no. That's 7, needs 3 more.
That has 7, needs 3 more. We'll move to item number 5, AB 1985 by Ms. Galgiani.
So moved.
We have a motion. Is there a second? Second by Ms. Carter. This is due pass to appropriations. Take the roll, please.
Monning?
Aye.
Monning, aye. Fletcher? Amiano? Amiano, aye. Carter? Carter, aye. Conway? Conway, aye. Brownlee? Brownlee, aye. De Leon? Adams?
Aye.
Adams, aye. Eng? Eng, aye. Gaines? Hayashi? Hayashi, aye. Hernandez? Jones? Lowenthal? Lowenthal, aye. Nava? Perez? Salas? Smythe? Strickland? Strickland, no. Hernandez, aye.
Yes.
Okay.
Galgiani. Item 5, AB 1985. That has 10. It's out. We're going to move to item number 6, AB 2042 by Mr. Fuhr. Is there a motion? We have a motion by Ms. Lowenthal, second by Ms. Brownlee. That's due pass as amended. Please call the roll. That's motion due pass as amended to appropriations.
Monning?
Aye.
Monning, aye. Fletcher? Fletcher, no. Amiano? Amiano, aye. Carter? Carter, aye. Conway? Conway, no. Brownlee? Brownlee, aye. De Leon? Adams?
No.
Adams, no. Eng? Eng, aye. Gaines? Hayashi? Hayashi, aye. Hernandez? Hernandez, aye. Jones? Lowenthal? Lowenthal, aye. Nava? Perez? Salas? Smythe? Smythe, no. Strickland? Strickland, no.
It has 8, needs 2 more. We're going to move to item number 9, AB 2153 by Mr. Liu.
So moved.
We have a motion from, who was that?
But we did that already.
It's done. I'm sorry. We'll move to item 10, AB 2173 by Mr. Bell. That's due pass to appropriations. Do we have a, that's been moved and seconded? No, we need a motion on Mr. Bell. Ms. Strickland moves. Ms. Lowenthal seconds. That's due pass to appropriations. Please call the roll.
Monning.
Aye.
Monning, aye. Fletcher.
Aye.
Fletcher, aye. Amiano. Amiano, aye. Carter. Carter, aye. Conway. Conway, aye. Brownlee. Brownlee, aye. De Leon. Adams.
No.
Adams, no. Eng. Eng, aye. Gaines. Hayashi. Hayashi, aye. Hernandez. Hernandez, aye. Jones. Lowenthal. Lowenthal, aye. Nava. Perez. Salas. Smythe. Smythe, aye. Strickland. Strickland, aye. Salas. Salas, aye.
That has 13. That's out. Are there any others of these that need? Should we do those? Or?
I thought it was.
No, this is Tarico.
No, we're
No.
voting on Bell's bill. Yeah.
Right. Okay. No. Mary, do you want to just make that on your microphone? We did. It's
Yes.
out.
When I arrived here, I thought that that was a consent bill. So on Assemblymember Bell's bill, I'm staying off of that bill.
Thank you, Ms. Salas. And now we do have some more bills that are still on call, members, but we are going to move to the final bill presentation from Ms. Salas. She is presenting on behalf of Mr. Tarico. This is item 13, AB 2456. This will be the final bill presentation of the afternoon, but I encourage members to stay with us. We have a couple of bills still on hold. Ms. Salas, good afternoon. Thank you.
Good afternoon, and thank you very much. I know it's been a real long day for all of us. I'm here to present on behalf of Assemblymember Tarico Bill 2456, and it's a bill that seeks to build on the bipartisan work of the legislature that adopted AB 2917 last session relating to emergency medical services. AB 2456 clarifies the Emergency Medical Services Authority's EMSA ability to establish guidelines directing local EMS agencies and other essential stakeholders in the effective coordinated delivery of emergency medical services. When firefighters or other safety or EMS personnel answer the call to a medical emergency.
It's a motion.
Okay. Would you like me to continue? I can continue with the statement, or I can introduce you to Christy Boma here, who is with the California Professional Firefighters, who is a bill sponsor. Would you like me to continue with the statement? Or? Okay, you'd rather talk to Christy.
Ms. Salas, I think it's fine to move to your witness. There are some amendments that the author has.
Yes, that's right. Okay, so let me get to that portion of it, because that is important. Let's see, and Mr. Tarico is respectfully going to take the author's amendments as noted in the analysis, and that is noted in the analysis. And in addition to that, to address the concerns of the California Hospital Association, we will be taking amendments to delete references to treatment protocols, and the amendments to change the word "and" is "for" in paragraph 4 of the subdivision E of the section 1797.184. So those were, in addition to the recommendations, the author's amendments in the analysis, that's the addition. And so Christy is here to answer additional detail.
Great. Thank you, Ms. Salas.
Mr. Chair, members of the committee, Christy Baumer representing the California Professional Firefighters, representing 30,000 firefighter EMTs statewide, who are, through this bill, simply seeking some standardization in the requirements relative to their certifications or licensure when operating as EMT 1s, 2s, or Ps in different counties. As you know, the fire service helps each other out throughout the state of California, and many of my firefighters must operate in multiple counties and should not be subject to different rules for different counties. This bill just asks the state to set up a standard It has absolutely nothing to do with the ability of a local medical director to determine what optional skills are conducted by an EMT in their county. It just says that if they do authorize a skill, the training for that skill is consistent, which is what we're seeking. We ask for your support.
Thank you. Other witnesses in support? Other witnesses in between?
Other witnesses clarifying positions, Mr. Chair and members, Connie Delgado Alvarez with the California Hospital Association. And yes, it is correct that with the amendments that were discussed just recently, we are going to be removing our opposition. We want to thank the author, his staff, and the sponsors for all of their work in addressing our concerns, so we will be removing our opposition.
Thank you for that clarification, and thank you for your work on that as well. Others in support or opposition?
In between. Hi,
In
I'm
between,
Lieutenant
okay.
Barbara Ferguson from San Bernardino County Sheriff's Department, and with the amendments, we're removing our opposition, and we'll have a neutral on it. Thank you.
Thank you. Other witnesses in support? Witnesses in opposition?
Good afternoon. My name is William Teufel, and I am representing MDAC, which is the Emergency Medical Systems Medical Directors Association of California. I am currently the EMS Medical Director for the County of Marin, which I've done for 5 years. You've already received our combined MSAC-MDAC statement of opposition to AB 2456. To make clearer the Medical Director's objections to this bill, I would like to briefly review a recent major medical policy and procedure change in our EMS system, and then comment on how the sweeping changes proposed in this bill would have impacted on this process. Around 5 years ago, a task force from the American College of Cardiology and American Heart Association published new guidelines for the care of ST elevation myocardial infarctions, which we refer to as STEMIs, a common form of heart attack. The recommended care was a cardiac catheterization with percutaneous coronary intervention, or PCI as we call it, within 90 minutes of the patient's hospital presentation. PCI refers to the removal of the blockage causing the MI. Both the EMS medical directors and the paramedic leadership had been anxiously awaiting this official recommendation so we could develop a pre-hospital system for rapidly identifying STEMIs, using paramedics providing 12 lead EKGs, and then reroute such patients to hospitals with this PCI capability. The LEMSA medical directors succeeded in implementing these changes in most of California quickly by what? Sharing our local problems and solutions through our quarterly meetings and our email list server. As is always the case in California, there were significant differences in local resources, medical politics, and geography. In Marin, where I work, we had to deal with a unique pilot cardiac program and a cardiology request for a policy where patients could request a hospital preference. The flexibility of our current EMS system, which allows the local EMS medical directors like me working collaboratively with local stakeholders to quickly create STEMI policy that was acceptable to all. Now let's imagine that AB 2456 had passed before this national guideline came out. Our only choice would have been to develop a statewide mandatory STEMI regulation. This regulation would have been developed by the EMS authority and then approved by the EMS Commission, and would have to fit all 31 LEMSA's needs, an impossible task. The EMS authority, with its now significantly increased and large staff, would have had to collect input from all 31 LEMSAs, plus all organizations with an interest in cardiac care, plus do an independent review of all the applicable medical literature. We would have had to wait 2 or 3 years for such a product, one that likely would have met primarily the needs of large, politically powerful counties. The significant and increased delays inherent in such a process would have compromised the care of hundreds of heart attack victims without any measurable benefit. Thank you.
Thank you.
I would just like to respond to that nothing in this bill would prevent LESMA County from making a policy or implementing procedures that have a unique application to their own jurisdiction.
Thank you, Ms. Salas. Other witnesses in opposition?
Good afternoon. My name is Dr. Karen First. I'm here representing HOAC, the Health Officers Association of California. HOAC is an organization that represents the 61 local health officers in counties and cities across the state of California. I serve as the health officer for San Joaquin County. As part of our role as health officers is to oversee the health of our communities and to promote policies that improve community health. HOAC is opposed to AB 2456. Medical control of the local emergency medical services system is by law vested in the local EMS agency medical director. Local EMS medical directors work closely with their hospitals, emergency departments, emergency physicians to set medical protocols for pre-hospital personnel that work best for their region. Due to the vast regional variations in EMS services across the state of California, it's essential that medical protocols for the pre-hospital emergency personnel be determined by the local level and the local EMS director. It's important that medical protocols take into account population of the jurisdiction, distance, geography, travel time to hospitals, varying capacity of the local hospitals, and availability of on-call physicians for various medical and surgical specialties. For example, a middle-aged man living in Palo Alto who has a severe heart attack or trauma, the best decision would be to get him to the Stanford Medical Center as quickly as possible. For the same man, if he was in a low-populated county where the closest emergency room is a small community hospital that in a neighboring county with a long traveling time, the best decision for the care by the pre-hospital emergency personnel would be very different. In this situation, it may include the provision of medications or necessitate the performance of procedures not needed in the other scenario. Also, this bill would require that all EMS medical policies be approved by the State EMS Commission, whose members are primarily non-physicians. This is, in essence, takes the medical decision and oversight out of the hands of the physician medical directors to the discretion of the primarily lay commission. This is an inappropriate way for medical decisions to be made and could result in inappropriate pre-hospital medical care. An additional concern is, as new medical recommendations are available from research, that this is the issue that my colleague just talked about, that it would be very difficult and very time-consuming for new medical research to get incorporated into local EMS policies. AB 2456 would severely restrict the local medical director's ability to make appropriate medical decisions for the local emergency medical systems. It would not serve the residents of California well and would adversely affect the health of the communities we serve. Therefore, we encourage you to oppose this bill.
Thank you. Other witnesses in opposition, and please state your name and your organizational affiliation. Thank you.
Judith Riegel with the County Health Executives Association and the California State Association of Counties in opposition.
Miles Julin with the Emergency Medical Services Administrators Association of California, representing all 31 local EMS agencies. Opposed.
Dan Birch, San Joaquin County. Opposed.
Jillian DeVorce with the Urban Counties Caucus. Opposed.
Tim Lynch on behalf of the San Bernardino County Board of Supervisors. Opposed to the bill.
Thank you. Any other witnesses in opposition? Seeing none, committee members, questions, comments? I have a question for the author, for Ms. Bauma. My understanding, part of the concern expressed by opponents is the concern of adaptation at the local level for local conditions. Could you just walk me through quickly how this bill protects that right for local adaptation?
Absolutely, Mr. Chair. If I followed everything that the medical experts to my left were recounting, this bill impact their ability locally to make that decision where it's rural area, urban area, although I may disagree that my medics are still going to deliver the highest level of care that they are authorized to deliver in that county. But what the scope of that delivery of care is still going to be determined by the medical director, will not be impacted by this bill. It will just make sure that if they do authorize some sort of an IV drug application in a county where they have longer response times, or if they actually have 12 lead EKGs, which many of us only have 2 lead that we could even diagnose a STEMI diagnosis, that we have the same training requirements for that skill. It should not differentiate because of what county I'm in performing that skill.
Thank you, Ms. Bauma. And Ms. Salas, I'm going to ask you to close, and I'm just going to repeat for committee members' benefit. The author has accepted the amendments at page 7 of the analysis, as well as some further amendments articulated at the close of Ms. Salas's testimony. Ms. Salas, I'd invite you to close on behalf of Mr. Tirico.
Yes, and this bill, quite simply, will ensure that when an EMT personnel arrive on the scene of a medical emergency, they have met a standard set of training, skills, and competency in order to deliver the best and highest level of patient care. This bill does not require medical guidelines, but policies and procedures and protocols applicable to EMTs in maintaining their certificates, their licenses, and their level of training to function effectively. And I ask for your aye vote.
Thank you, Ms. Salas. We have a motion, do pass as amended, and refer to appropriations. We have a motion from Ms. Lowenthal. Is there a second? Second from Ms. Brownlee. Please call the roll.
Monning?
Aye.
Monning, aye. Fletcher?
Aye.
Fletcher, aye. Amiano? Amiano, aye. Carter? Carter, aye. Conway? Conway, aye. Brownlee? Brownlee, aye. De Leon? Adams? Eng? Eng, aye. Gaines? Hayashi? Hayashi, aye.
No.
Adams, no. Hernandez? Hernandez, aye. Jones? Jones, aye. Lowenthal? Lowenthal, aye. Nava? Perez? Salas?
Aye.
Salas, aye. Smythe? Smythe, aye. Strickland? Strickland, aye.
That has 14. That bill is out. Thank you, Ms. Salas.
Thank you on behalf of Assemblymember Tirico.
Thank you. Okay, members, we are through our bill presentations. We do have a number of bills on call. I'm going to take those in file item order, starting with item number 1, AB 1759 by Mr. Blumenfield. Please call the roll.
Amiano? Aye. Amiano, aye. De Leon? Gaines? Hernandez? Aye. Hernandez, aye. Jones? Aye. Jones, aye. Nava? Perez? Salas? Salas, aye. Strickland? No. Strickland, no. Gaines, no.
Let us go through these, if you don't mind waiting. Is it on this one, on Blumenfield? Ms. Carter wants to change her vote on this Blumenfield bill. AB, what's your vote?
Not voting.
Carter not voting. Makes it 8.
That has 8 votes, 2 short. Let's move to item number 2, file item 2, AB 1916 by Mr. Davis. Please call the roll.
Amiano? Aye. Amiano, aye. De Leon? Gaines? Gaines, no. Hernandez? 1916? Aye. Hernandez, aye. Jones? Aye. Jones, aye. Nava? Aye. Perez? Salas? Salas, aye.
That's okay. Jump to that right now. What is that?
It's out. It's got 11.
That's out. That's Mr. Davis's. Before we move to Mr. Cook, as a courtesy to Mr. Adams, we're going to look at item 14, AB 2586 by Mr. Chesbro, and I'm going to ask the clerk to call the roll on that. Item 14, AB 2586. Mr. Adams is going to change his vote. Would you want to announce that?
I'd like to change my vote from no to aye.
Well, it's not voting.
Not voting to
Adams, aye. Amiano? Aye. Amiano, aye. Conway? Conway, no. Brownlee? Brownlee, aye. De Leon? Gaines? Gaines, no. Jones? Nava? Salas? No. Salas, no. Strickland? No. Strickland, no. Needs one more, has 9.
That has 9. It needs one more. I'm now going to go back to file item number 4, Mr. Cook, AB 1976. That needs 6 votes to get out. Please call the roll.
Fletcher?
Aye.
Fletcher, aye. Amiano? Amiano, aye. Conway? Conway, aye. Brownlee? Brownlee, no. De Leon? Eng? Hayashi? Hayashi, no. Jones? Jones, aye. Lowenthal? Nava? Strickland? Needs 2.
That needs 2. We're moving to file item 6, AB 2042. Mr. Fuhrer. Please call the absent members.
De Leon? Gaines? No. Gaines, no. Jones? Jones, aye. Nava? Perez? Salas? Aye. Salas, aye. That has 10, it's out.
That has 10, it's out. Moving to file item 9, AB 2153 by Mr. Liu. Please call absent members.
Amiano? Aye. Amiano, aye. Brownlee? Aye. Brownlee, aye. De Leon? Gaines? Aye. Gaines, aye. Hernandez? Aye. Hernandez, aye. Jones? Aye. Jones, aye. Nava? Perez? Salas? Aye. Salas, aye. Strickland? No. Strickland, no. That's out.
Okay. That is out for, that was file item 9, AB 2153. That is out. Going to entertain a changed vote from Mr. Amiano on file item 4, AB 1976 by Mr. Cook. Mr. Amiano, would you announce your change vote, please?
From aye to no.
And
Amiano, aye to no.
this is file item 4, AB 1976. Mr. Jones?
Aye to no.
Aye to no, Mr. Jones.
Jones, aye to no. It's at 6.
Okay. Madam Clerk, how many are still on call or short? In just a second. We're gonna.
What were the consent items?
Just before we jump here, let me answer that. Hold on once. Consent.
Can I add them to the consent?
Yes, and I want to see if we have roll calls, then we'll do it anyways. Okay, let me just, before we move to add-ons, we have three bills still on call. Item 1, Item 4, and Item 14. I'm going to leave the roll open. I'm going to invite members who want to add on now to do so with the clerk. I'll keep the... Can't add on to bills on call. So bills that have already passed out, you're welcome to add on. We're going to keep the committee hearing open on the three bills that are on call.
What I have is Manny Perez.
Members, we have items 1, 4, and 14 on call. We're going to open the roll on item number 1, AB 1759. Please call absent members. Mr. Blumenfield's bill.
De Leon? De Leon, aye. Nava? Nava, aye. Perez? That has 10. It's out.
That has 10. It's out.
Item 4.
Item 4, AB 1976 by Mr. Cook. Please call the roll. Absent members.
De Leon? No. De Leon, no. Nava?
Yes, Ms. Lowenthal, your vote change on this?
From not voting to
Strickland?
no.
From not voting to no.
Item 4.
And Ms. Lowenthal changed her vote. Did you hear that?
From not voting to.
From not voting to no.
Lowenthal not voting to no. Still has 6.
That has 6 for Mr. Cook on item 4. Item 14.
Right.
AB 2586, Mr. Chesbro. Please call the roll for absent members.
De Leon?
Yeah.
De Leon, aye. Nava? Aye. Nava, aye. That has 11.
That has 11. Mr. Chesbro's bill is out. So what's left? It's
Mr. Cook's bill.
just Cook.
Mm-hmm.
Yeah, I think it's not going to make. I told the sergeants I'd stay here till 1:15, so Pat has one to come back and hang in. Do you need me in that committee to vote? I'm on ENT. Probably.